Good morning to one and all here. Thanks for giving me the opportunity to introduce Dr. Vikram Datta, sir. I think he is, if you say QI, which will be, you'll never forget one person is Dr. Professor Vikram Datta. So he is actually the director and professor. He is the director, I'm going to take the call. He is a director and professor in Lady Harding, Department of Neonatology. And then he is the president of the National Quality Care Network. He's the vice president-elect 2022 National Neonatology Forum. He's a guest editor for BMJ Open Quality for South Asian edition. He's a member editorial board in the International Journal for Quality in Healthcare, an expert at the International Society for Quality in Healthcare. And then he's a lead national mentoring group and technical resource group lead, sustainable model for Lakshya, that's the government program. And then he's a member of QED, that is Quality, Equity, Dignity Working Group from the Ministry of Health and Family Welfare. So we are proud and we really feel honored to have you here in this workshop. And of course, he's a mentor for all of us also. And he's been with us, guiding through how to conduct this workshop and helped us and guided us. And he's been of immense help to us. And without wasting much time, I think I would like to hear the words of wisdom from Vikram Datta, sir. Over to you, sir. Thank you so much for joining us in spite of your busy schedule.
Thank you so much, Dr. Prakash, Dr. Sarath, and good morning to all friends in Bangalore and all NNF colleagues who have joined online. I think there was some last minute glitch which led to some of us joining into the wrong workshop, and that included me as well. And I think we will have more people joining as I continue to speak, and we will have some people on site also. Friends, I would like to congratulate you for taking time out and coming together to learn about the fascinating topic of quality improvement. I will just take you through a brief presentation which will tell you why quality improvement is important and how it can help you in neonatology and what is the way forward. So if Dr. Prakash permits me, I would just go ahead with the presentation.
Yes, sir.
Thank you so much, Prakash.
Yes, sir.
I'm sure my slides are visible to you now. Okay. So I would just be speaking on quality improvement strategies to improve neonatal outcomes. Friends, you all know that we are belonging to a great organization, that is the National Neonatology Forum of India. And it is under the auspicious occasion of the NeoCon at Bengaluru today that we have all assembled to reiterate for the cause of the newborn survival. Now, I would just take you through some photographs. And if you look at these photographs, this is a classical photograph from some of the SNCUs or the special newborn care units, which have come up nearly 840 plus SNCUs at district headquarters. This is a typical scene which you see here, more than 2 to 3 babies lying on each of the radiant warmers. This is how most of our newborn babies still arrive at district hospitals through unspecialized transport ambulances in cold weather. This is how the babies are received at the community health centers and primary health centers. You can see cyanosed, hypothermic, often limp, not breathing, with a sketchy referral note. And this is a short video which will show you how these babies are transported from arrival to the special care newborn unit. And when you see this in the hands of the nurse, this is not a piece of cloth, but this is a living newborn baby. And you can understand the issues of patient safety, respect of the newborn, and what type of quality of care we are delivering to this newborn. Now, this newborn, when he goes inside the SNCU, you can see the condition of the baby: absolutely limp, absolutely pale, hypothermic, and look at the position of the baby and the various factors which will come into play. Now, if we get a newborn like this, then it becomes very, very important for us to make sure that this baby survives. Now, these are some photographs which are from medical colleges, the postnatal wards and the neonatal wards, as well as the labor rooms. And mind you, these are photographs from the medical colleges on a day of Government of India team visiting them. So you can understand the status of affairs subsequently. This is how most of the SNCUs or the district hospitals or the nursing units are delivering medications, including IV fluids, how the equipments are lying malfunctioned, and how IV fluids are being given. And these are the photographs from the doctor's duty room, the washing area of the newborn care unit, the changing area for the doctors and the nurses with the brooms and the inverter and the battery and the gowns all kept. And this is as recent as 7 days back, during the time of the newborn week visits. Now, friends, by seeing these photographs, you must be wondering that what will happen to the neonatal outcome? Well, we are all worried for the neonatal outcome, and that is why we gather together in conferences like NeoCon, because we want to advocate for intact outcome. Now, there are multiple factors which affect the neonatal outcome. And if you are aware, Government of India has given 6 or 7 areas of concern which need to be fixed for you to have an intact outcome of your patient. The first is the service provision. Second is the patient rights. The third is the inputs, support services, clinical services, infection control, and last comes the quality management. Now, if you look at it, you can fix most of these parts by providing inputs, infrastructural inputs, etc. But how can you fix your support services, clinical services without having a good quality management? Now, why we are concerned about quality management is that the number of individuals who are dying because of poor quality of care is the largest in cases which are having cardiovascular disease. Whereas for us as neonatologists, the number of deaths of newborns which happen because of poor quality of care is second only to cardiovascular diseases. So friends, you can understand here that we are losing a large number of newborns because of poor quality of care. And 98% of this mortality is happening in low and middle income countries, of which India is a part. We are contributing to nearly 26% of the global newborn mortality. And mind you, if I aggregate all the diseases and all the clinical domains, then nearly 5 million people every year are losing their lives because of poor quality of care after reaching the hospital. They reach the hospital thinking that they would get an intact outcome, but they end up getting wrapped up in a shroud or in a coffin going for the cremation. So poor quality is now a greater contributor to mortality than non-utilization. And we need to focus on this. Now, when I talk about quality, quality varies according to various states. You're sitting in Karnataka right now. Let's focus on Karnataka. This is data from India Newborn Action Plan. You can see there is nearly more than 2-fold difference between your rural and your urban neonatal mortality. What does it mean, friends? It means that there is tremendous inequity in our country. As far as the health services are concerned, this is the line of equity, and most of our country, except a couple of states, are below the line of equity. And what does it mean? That our healthcare services are not equitable. And equity is one of the major components of quality. Now, you must be thinking why I'm talking about all of these things in a workshop. Well, it is to put the background very straight, why we need to understand it, and why the sooner the better. You may learn about fancy ventilation techniques. You may learn about fancy CPAP techniques. You may learn about fancy TPN. But remember, unless and until you can fix the quality, you'll continue to lose babies. And you may save maybe 5 or 10 babies in an ICU. What difference does it make for a country as big as India, or a region as big as Southeast Asia, or a planet as big as the planet Earth? Well, friends, unless and until we can fix the quality of care, we cannot prevent 75% of the preventable neonatal deaths. And it is a well-known fact that if we focus on the area which is the care around the birth, we can save nearly 3 million lives of newborns, their mothers, and otherwise destined stillbirth babies. Now, that is something which is a big number, and that is what has brought Government of India's attention to focus on quality. Because friends, if your utilization of your hospital, the number of footfalls are more than 100%, and if your quality is 0%, you multiply the utilization of 100 with a quality of 0, what do you think your health outcome is going to be? I'm sure we all know this much of maths, that utilization of 100 multiplied by quality of 0, the health outcome is going to be 0. And this is what was rapidly, recognized by Government of India. And Government of India launched these 3 beautiful programs, which are very futuristic. And the program I'm proud to mention here, that Nationwide Quality of Care Network, of which I represent as a national president, and NNF India are signatories to being the major partner of the Muskaan program. The Muskaan is ensuring quality in child-friendly services in public health facilities. And Lakshya is Labor Room Quality Improvement Initiative. That is, that we cannot have an intact neonatal outcome unless and until we have good antenatal and perinatal and immediate postnatal care of the mother. So these are the 3 national programs which are looking directly at quality certifications and quality improvement, and have beautifully amalgamated the quality improvement process with quality assurance mechanisms. I'm sure my friends are going to be talking more about quality improvement, but why we are talking here about quality improvement is that many of you or your colleagues would be attending workshops today. Let us see what effect size attending a workshop has. Only 10.3%, my friends. And what does it mean? That 90% of the people who are going to attend a workshop today will continue to do the work the way they were doing it. And only 10 people out of 100 are going to change. Well, what does that mean? That means that we have to invest in not only training, but adding quality improvement into training, which has got the largest effect size of 56%. So if I want to change the way my team works, I have to invest in quality improvement. And that is, friends, a futuristic investment. And I'm sure all of us are going to realize it. The sooner we realize it, the better. Otherwise, we are going to learn it the hard way. And that is precisely the reason why we need to be very, very careful about it. Now, how quality improvement can improve neonatal healthcare? Quality improvement can help you in identifying the key contextual factors which cause problems in your setup. It helps you in identifying the root causes of these problems, and my team here is going to be taking you through all of these. It is going to help you to develop change ideas, and these change ideas, which are your team's change ideas, will be utilized by a PDSA methodology, that is a Plan, Do, Study, Act methodology. And we have structured sessions today which will take you through the PDSA methodology. And you will learn how you can implement the successful ideas and learn from the ideas which did not work. And lastly, all of you can cross-learn into forums like this, creating national QI collaboratives. So friends, the moment right now is to connect and empower and help each other. We all had the will to improve. We all had the ideas. But till now, the execution plan was missing. Friends, this quality improvement workshop is going to give you an execution plan to implement your ideas with a strong will. And it will also help you to fix the gap, which is the biggest gap in our life. And this is the no-do gap. We know quite a bit, but we practice quite little. Friends, what we have to do at this point is to bridge this gap. So let's fix this gap and let's practice what we know rather than knowing too much, but practicing very little. And let's see how we did it at our point of care facilities. Well, we used a simple 4-step approach for delivering quality of care called POCI, that is the Point of Care Quality Improvement Methodology, which is devised by WHO. And I'm proud to mention here that we are contributors to one of the case studies into this and contributors to the manual of WHO. You have to add the clinical skill, and we added, you can see an online mentoring session which is happening here, and a physical mentoring session for the mothers and a counseling session. Then third is frequent on-site online coachings. And fourth is the BMJ Open Quality, that is the documentation and the dissemination. So whatever stories you learn, you have to document and disseminate for others to learn. So till now, we have touched 103 million lives across 15 states of India, and we currently work across the Southeast Asia regional network of WHO. We've touched over 1 million lives. We run a very successful partnership, both at the macro, at the meso level, and the micro level with the frontline facilities. And during the pandemic, we have partnered with the British Medical Journal, and we have launched a Southeast Asia Communities of Practice with the partnerships of organizations like BMJ, ISQA, URC, Oxford, and the World Health Organization as a supporting partner. So I take this opportunity to invite all of you to visit the communities of practice, that is the NQCN communities of practice, and learn from the various implementation models, which are the field implementation models. So what you learn from here today is not meant to be kept in your heart or on the shelf of your office. It needs to spread. And friends, how it is going to spread? So if you are working in a medical college, you have to handle the PHCs and the CHCs. If you're working in a district hospital, you have to connect to the medical colleges and you have to cross mentor your PHCs and CSCs. So this is a hub and spoke model. And if you are working in isolation or you're working a standalone facility, you can join this very successful communities of practice and become a part of the larger regional network for quality improvement, which we are running for nearly 2 years now. So these are how we implement our point of care quality improvement using the translating research into practice framework. I'm not going to bore you with telling details of this, but you need to understand this. I have a QR code which can be scanned for people who would like to know more about how you can take this to scale. What you learn, how you can take it to scale and implement it across various healthcare facilities. And lastly, friends, I would just like to tell you here that what you learned here today, you can fix neonatal hypothermia, which is a great killer. And you see here that we reduced neonatal hypothermia by 38% and reduced mortality. In our setups, you can reduce late onset sepsis. You can introduce care around the birth packages. You can introduce kangaroo mother care adoption and scale up bundles, perinatal asphyxia reduction bundles. You can work in the direction of preventing infections. And if you are interested and you work in a rural or a suburban setup, you can talk to your primary healthcare workers and get quality improvement adaptations for them. So friends, these are some of the things where you are going to work here today. So this workshop is going to take you through the steps of the PDSA cycles and implementation of QI interventions. But remember, if you want to make a change in the healthcare system, which is very, very important because you may learn the skill, but if your healthcare system is working the old way, it will be very difficult for you to, bring about a change in your setup. You need to have a good leadership. You need to have good assessment of your problems with good standards of care and with good stakeholder and community engagement. So friends, I end my presentation now by mentioning a couple of very important points. Remember that we all want people to work well. Let's work well. Let's get trained. Let's perform to the best of our abilities. Let's give good quality care. But how? If we ourselves are not happy or we don't find joy in our work, do you think we are going to deliver high quality care? Well, the answer is no. Do you know that our country ranks 144 in a list of 153 countries on the happiness index? And you will say how happiness affects the quality of care. I'm leaving you with this slide, which tells you that if you are joyous at your work, you have less medication errors, you have less waste, you have high productivity, and you have less absenteeism, as well as reduced turnover time and leading to better financial performance. So, friends, let's work towards getting joy into our work and making people feel happy and satisfied and contented and feeling that they are working for a cause. And there are some prerequisites to bring about quality. This workshop is not going to be discussing about elements of psychological safety. We have a full course on psychological safety on the communities of practice. You could visit that. So, psychological safety means that you can dissent with your boss or from somebody who's higher up in the hierarchy without the fear of any retribution. Well, that is physical and psychological safety. Just question yourself, do you have it in your setup? If the answer is yes, then you are in a good place. But if the answer is no, most of these things except teamwork and maybe a little bit about participative leadership. We need to find these 6 building blocks, which are the prerequisites, or I would say the foundation stone for any setup to have good quality of care. So the way forward, you may think, unfortunately, I would be inclined from being on the way to Bangalore, so I will not be able to. Sure. What you take home from here is that you have to remember that the baseline for any quality improvement work is good data. Let's say you have raw data, not sharing anonymous data. Whatever little data, maybe your breastfeeding rate, maybe your anemia rate, maybe your infection rate, maybe your patient satisfaction scores. So whatever data you have, start sharing it. Try to form your team and try to plan for facilities which are not as fortunate as yours and try and give them a metric plan. Force partnerships. And very important. Always, whatever you are learning here today, go back and inform your leadership. Very, very important. Because unless you have the leadership on board, you cannot change and you cannot change and create a QI culture. So very, very important. The QI culture starts from me. So I have to be the change which I want to see in the society. And here I also from other organizations. Lastly, no quality improvement can happen without the partnership of an empowered community. Try to get the mothers into your eyes. Try to hear to their silent gestures. Try to understand their body language and try to connect with them. Don't feel frightened that they are observing you. They will be subject to it. Let's work together, friends. And as it is rightly said by Buddha, we all know the way, but very few actually walk it. So quality improvement is nothing but a common sense approach within the same resources, which makes you more efficient, more happy, and more contented with an active partnership of the community. So I now leave you with the chance of Mr. my co-national coordinator and Dr. Prakash and the team facilitators, Dr. Umar and other colleagues, and Mr. Buddha. I hope to see you all in the evening in Bangalore. So thank you so much. I will now stop it here. If there are any questions, I will be very happy to answer. Over to you, Prakash.
Thank you so much, sir. I think I think the slides which you have projected would definitely anyone would kindle their mind to start on, do the improvement quality in their area. And as you rightly said, that this workshop is going to concentrate on the more of the what you do on the field, and we'll take it from there and under your guidance. And thank you so much for that nice presentation, sir. And we would then should we we'll move on to the workshop now, sir. If you We'll see you in the evening, sir. Thank you so much, sir. Thank you so much.
Thank you, sir. Well, thank you, friends, sir, for joining on your busy schedule, and I know that you will be following now. We'll be starting up the workshop with the role play. There's a power cut here. Probably give us 2 minutes, and then we'll start up with the role play now.
Thank you so much. So with this, we'll go on to the thing. The plan of this workshop will be like what we are intending to do is, so we will do a role play where what is usually done in the unit, and then and then from there we learn on how. From there we will just learn on with each and every step how do we go about it. So first is will be a role play, followed by a session related to that role play, and then we'll come back to the right way of doing it. And then we'll have hands-on sessions where we will be sharing some of the things with you online also. So you can
for patiently waiting for this last minute glitch. So we'll start off with a role play. So the idea of this role play is to sensitize all the participants about how things work out in the NICU and how quality improvement can improve the working style in your unit. So I invite all the facilitators for this role play. So in this role play, we'd have Dr. Prakash sir as the consultant who is taking rounds. So basically we are in a level 3 NICU, and it is the morning 9 o'clock, and it's the time for rounds, and Dr. Prakash is the consultant who has just joined rounds. So Dr. Usha is the senior resident, and she's exam going resident. She's a senior, and we have Dr. Sharath, who is the first year resident. We have Dr. Ashok, he's a quality nurse, who is a skin nurse. And we have Dr. Uma. So Dr. Uma would be playing a role of the bedside nurse. So the scenario is that we have a baby of N, who was delivered yesterday night at 10 o'clock. So this baby was born out of a emergency cesarean section. So this is a 29-weeker, 1.1 kilo baby, delivered by emergency LSCS in view of pregnancy-induced hypertension, uncontrolled BP, and the baby also had absent end diastolic flow. So the Apgars were fine. The baby was started on delivery room CPAP, shifted to an ICU, and required early rescue surfactant given through Ensure method. Then the baby was put on CPAP. Currently, the baby is on a CPAP of 5 centimeter and an FiO2 of 21%. The baby was started on TPN with minimal enteral nutrition. So over to the scenario. Yeah. So yeah. So over to you, sir.
Thank you. Yeah, Dr. Usha, have you seen the baby?
Good morning, sir. Yes, sir, we have seen the baby, sir.
Can you say, what do you think we can improve on the outcome of this baby with VLBW?
Sir, he was delivered yesterday, this baby was delivered yesterday night, and admission temperature was normal, sir. And we have started on early CPAP, and we have given early rescue surfactant, and we have put a central line. We have started on fluids, we have maintained normoglycemia, and today morning now we are starting on total parental nutrition, sir. We have we have given optimal care for the baby till now, sir.
So there will be always be opportunities to move on. So do you think anything else that you like to implement here, which you think the the outcome of VLBW will improve?
Sir, actually, this baby came yesterday night, so we could have started total parental nutrition in the night itself. But due to non-availability of staff and logistic reasons, we started now only, sir. But we have started minimal feeds for the baby. And we tried to do echo, sir, yesterday. We asked for the scan machine. We asked for the scan machine from the radiology room. Even Dr. Sarath went to radiology room and requested for the scan machine, but it was not free, and we could not get scan machine. We did not do echo for the baby, sir. So these both things we could have done. For this, we have given all the optimal care, sir. Baby came in the night, so maybe we could have started total parental nutrition yesterday night only. But due to non-availability of staff and resource limitation, we didn't start in the night. We started total parental nutrition now only, sir. And echo machine. We wanted to do echo for this baby as well, but echo machine we called and asked the radiology room. We couldn't get the scan machine. Even Dr. Sharath went in person and tried to get the scan machine, but it was very busy in the radiology department. They didn't give the scan machine, sir. So both these things we could have done. That's what both of us feel, sir.
Okay, is there any preventive this thing you could think of in improving VLBWs?
Sir, maybe what we could have done, these two things we could have done, and as such, prevention of prematurity would be the ideal one. If we could prolong the pregnancy for some more time, then all the complications could have been avoided, and that will be the ideal one, sir. And other things I told, these two things we thought we could have added on to the care of the baby, sir.
Okay, so yeah, I saw somebody coming in. Yes. Oh, you're the skin nurse. So hi. I'm seeing you for the first time. Yes. So what are you doing with the baby?
I am the skin nurse, sir. So I am here for the past 6 months, and hospital management has asked us to see the skin care. So we are taking an audit of all the skin injuries. So I'm just seeing this baby has got a nasal injury, sir. You only see, sir, what care these people are giving.
What? Is that a skin injury? What, Dr. Usha and Dr. Sharath, did you not notice that? Where is the nurse of this baby? How? Yes, sister, what is this, sister? What is happening here?
We did not check, sir.
Why are you not checking?
Doctors are checking, sir.
So, don't you think that on baby on CPAP, you should be checking, is there a nasal injury or not?
We don't see usually nasal injury. Doctors only see, sir.
Is it so? What about you, doctors?
Sir, actually, yesterday night it was busy, sir, and I personally didn't remove the mask and see for nasal injury. We thought that sister would have checked whenever they whenever they took over the baby. We thought that sister would have checked and took over the baby, sir. So sorry, sir, it should not have happened.
Morning we have seen only on the outside, sir. We did not remove the mask and see. And rounds were very busy, and unit is very busy. So we thought nurse would have seen it.
So you all are having X-ray eyes to go through this thing to see the nasal injury. Okay, yeah, sister. I think it is your job to definitely see, and I think all the doctors should also see. I don't know. Somehow you do and you plan among yourself. I just don't want nasal injury next time. Okay, so I'm very upset. I'm leaving this. I'll come and resume rounds after some time.
Doctor, you could have seen, isn't it, doctor? Like we are taking care of 5 babies. How am I supposed to see all the babies?
But it is basic nursing work that you need to look into the baby, right? Even we are busy, both of us have been going around, running around the casualty also.
Usha doctor knows we need to take care of this.
No, sister, it is nurse's responsibility. Every shift you need to look for nasal injury and then only you should take over the baby. You cannot put the blame on us, sister.
Doctor, you know that this unit is so busy. I am taking care all alone 6 babies. So each and every baby, like how am I supposed to see, doctor? Like I think like when you were doing first year, you used to see, right? So I think doctors only can see because nurses we are very busy. We have to give feeding. We have to uh, do all the other instructions also you are giving. So we are busy, doctor.
Anyway, I'm busy with my thesis planning, so I have to submit within this week. I need to do that.
I'm also exam going and I cannot concentrate on all these small things. You need to take care, sister.
Okay, so have you planned? Process?
I'll also look during the rounds, and nurse will also have a look at all the babies. But I have to prepare for my thesis, so I have only a week to decide on the topics. So I need to really sit down and decide on it.
Sharath, what we will do is anyway you are looking for your thesis, no? What you will do, that skin nurse is telling there has been so much of nasal injuries in the past 6 months. So what you have not arrived at the thesis topic and sir is also very angry on you. So we will take the 6 months data and then we will give education to the sister. We will ask them to check during every shift and we will see in the coming 6 months how it is improving, how the nasal injury is coming down. Okay, so we can take it as a pre-intervention or post-intervention study, something like that. And you can finish off your thesis soon. In 1 year only you can finish off the thesis. So that one you can tell and impress our HOD, sir.
But will I have enough number of cases for that?
I will do one thing, doctor. Shall I go and get the skin nurse? She has all the data collected. He has been collecting for last 6 months. Initially, one more person. Now, new person has joined, and he is also collecting. Shall I get the data for you? Then, Sharath, Dr. Sharath, doctor will take care.
Sure, will do that.
Okay, I was hearing your conversations. So we have decided to do a thesis on quality initiatives. Yeah, so how are you going to frame? What is your aim of your study?
We'll try to reduce the number of nasal injuries for all the babies that were on CPAP for the for the next 6 months. I'll ask the skin nurse to.
So data is there, sir. I have submitted to quality. Every monthly I'm giving. I have not seen or analyzed. Maybe I will just check and come, sir.
So after you see a skin injury, what do you do with it?
So my job is to give it to quality team.
So what do they do after that? Okay, you don't know. Okay. So okay, I think it is good that you have the this thing and you can start on. So what aim would you like to? With what aim would you like to do your thesis?
Last month, 10 babies has nasal injuries out of 20 babies. So some redness.
We'll try to bring down the number of nasal injuries to 0 from 10.
Right. So I think you need to go through formal training to how to do a quality initiatives. It's not like we plan and then just like do some interventions. There are ways to do it and see what you implemented and things like that. I think there is a workshop in Neocon happening in Bangalore. I think that you need to go to that, attend that workshop, understand how to do quality initiatives, and then you come back to me with your planning. Yes, right.
Thank you, sir. I'll do.
Thank you, sir.
So all of you must have seen the role play. So what? So do you relate this to your unit? What's happening in your unit? So if any one of you could put in the chat box, if you have been exposed to QI, so what errors were the panelists doing here? So could anyone suggest, or you could just put it in the chat box so that we can read it out. Sir, would you
Akshay
like
sir.
to comment, sir?
This is, I think, hello. The scenario which just presented by team is very much common in NICUs. Mostly we tend to neglect towards small things, small skin injuries. Most of the time we use cotton stickings, Dynaplast to fix the feeding tubes and our temperature probe. And when we remove the this thing, the sticking, we see that the underlying skin is very much damaged, and the baby which was not septic before becomes septic, and we get raised CRP and raised counts, and we tend to now then step up our antibiotic support, and we make a mess out of a very small thing. That is what my common experience. So as practicing pediatricians, we should be always be very much careful and have a kind heart towards these small babies, and use our paper stickings, which is very much this thing. And skin, being the largest organ of body, needs to be looked very carefully. We should not underestimate importance of intact skin in our NICU. Thank you.
Okay, so we have a chat from Dr. Amulya. So she has rightly pointed out that there has been a blame game. So the senior resident and the nurse were blaming each other for having to take the responsibility of checking the skin. So yes, there is poor teamwork. There are many people who are working for the baby, but there is no clear role allocation on who has to do what. And as rightly pointed out, yes, the skin nurse has been collecting data, and it's a burden on the system. But what is happening to the data? Are you analyzing it properly, and are you translating it to actionable results? The answer is no. So just to add this, if you would have listened, so Dr. Usha was telling she wanted to decrease prematurity. So yes, that is a good aim, but do you think it is achievable, and to what extent is it possible? So here comes the role of QI, and so we have structured sessions to train you in all these aspects, and so that you could implement these in your units. And after we complete these sessions, so you can see how these questions would be addressed in those sessions. So to begin with, we'll have first session by Dr. Uma. So, okay, Dr. Usha. Okay. So we can have the slides, please.
Hi, good morning, one and all. This is Dr. Usha. I'm from Department of Neonatology, Chettinad Hospital. So before by the time the PowerPoint is getting open, so what shall we do is, we'll just see what do you think is the basic difference between a research project as such. We have done many theses during our PG time, or maybe in the specialty or during fellowship. So what is the basic difference between a normal research study and a quality improvement initiative? What do we, maybe you can post your answers in the chat box, or if you want to unmute and talk, that also you can do. So what do you think is a basic difference? Some of the differences, whatever you think, you can just list out. Yes, sir.
What I think is this quality initiative program is more for the implementation purpose. We know, as Vikram Datta sir rightly pointed out, we know too many things, but we hardly practice in our daily routine. So the difference between our routine thesis and this quality improvement is implementation of knowledge in our routine daily activities.
Thank you, sir. So, like what sir has rightly told, quality improvement is more into implementation when compared to other research projects. Okay, you might take up a research project like umbilical cord milking instead of delayed cord clamping. You can take a research project like that. Once the person finishes the thesis or the study is over after 6 months, it might be incorporated in your unit protocol or you might not follow that as well. This is just for finishing of the thesis and completion of a study. So the research project, though the outcome might be better, yes, umbilical cord milking is doing good to the babies. You might have understood that after the research project. But there is no urgency or emergency in implementing in your day-to-day practice. Even after that, people will be conducting deliveries, but umbilical cord milking or delayed cord clamping might not be done in the babies. Okay. So, but in a quality improvement, what we are trying to do is, we are finding out what is the problem and we are implementing a change. And this change has to be followed day to day in the unit, in the normal quality of care of the babies, and it will be sustained after that also. And any other answers in the chat box? Dr. Amulya, Dr. Shamini, Dr. Namita, any other answers you could think of? Like how does a research study differs from QI? So research study might be a long-term project. QI might be taking a short time. What else?
Yes.
Yeah, Dr.
Apart
Amulya
from that,
wants
it
to
helps
answer.
us to
Yes, Dr. Amulya.
yeah. Apart from that, it helps us to bring some changes and to assess like what your working pattern. If that pattern is the best, we all assume that what pattern we are working is the best pattern. But there are other patterns which we have to be receptive to and receptive to change, and to bring in a change in a unit to make the thinking of the entire unit is a challenge, because you have to convince the nurses, you have to convince the other helpers in the unit. Apart from that, our doctors, our juniors, our seniors, all of them have to be convinced to take that step towards an improved quality. What they believe, what they're doing is the right way of doing. So that has to change. For that, leadership quality has to be there in the person who is managing the unit. So that has to be there in all persons involved in quality improvement projects.
Very good, Dr. Amulya. So, quality improvement initiative is a teamwork. But when you select a research study, only 1% or 2% might be too much involved in that research study, and they might be too much interested to complete their study. Whereas in a QI, all the team members will be equally involved. You want to say something else?
Yes.
Usually our thesis finishes within a year and 2 year. We hardly people bother about that, what was the thesis and what we did in that thesis and what was the outcome of the thesis. But quality improvement initiative, that change has to be there persistent throughout the life, and it's not just a wish or something like that. It has to be there as a part of, it is something which is must and has to be done by everyone, and it has to be consistent. Consistency matters a lot, and the leadership has to take a stand for it. Commitment matters a lot in quality improvement. That's what I think.
Yes, sir. Like what you told, sustenance. It will be sustaining in the unit day-to-day care practice even after the project is over. That is more important in a QI. But research study, you might find an intervention to be very useful, but you will leave it off after the study. And when a junior joins freshly, he doesn't even know that such an intervention was done in this unit. So that is the fate of all the other research studies. Okay, going into the first. And in QA study, if you see, yeah, can you hear me? Okay. So, and if you take a QA study, mostly there will be a standard quality of care that should be given to the babies in NICU. But there might be some defect in the process of quality of care which you are giving in your unit. So, we are doing the QA to improve that quality of care. Whereas in a research study, you might be introducing a new intervention, which is not the standard. Suppose you are introducing less invasive surfactant administration using a nasogastric tube. That is not regularly followed in the unit, and that is not recommended as a standard quality of care. So that is a new intervention. Whereas in quality initiative already established standard of quality of care, you are trying to reinforce and you are making sure it is followed 100% in your unit for the improvement in neonatal outcomes. So this is another difference. So only as we are implementing the same standard quality, many a times IRB approval is not needed for a QA study, whereas IRB approval is a must when you do some other research study. That is also there. Okay. And
recording in progress.
So 1 minute, please. Yeah. Can you see the slides? Okay. So we'll go to the first topic. Now that we have understood there is a problem in the unit which did that role play. There is a nasal injury where there is blame game going on, and we'll try to solve it with this lecture. How to select an appropriate QI for your unit. How to identify the problem, how to form a team, and how you are going to set your objective or aim statement. Okay. Next slide. Okay. I'll use slide. Okay. So most of the slides in this presentation have been adapted from POCU guide. If you go to www.pocu.org, there is more resource materials regarding the QA initiative, which can be used for learning as well as doing a study in your unit. Okay. So we'll be dealing, in the coming 15 minutes, we'll be dealing about how to identify a problem in your unit. So is it seen, sir? Slide is seen? Okay. So how to identify a problem, how to prioritize which problem you are going to address, and you are going to form a team and you are going to write an aim statement. So, first of all, how to review data to identify problems. We saw, no, a skin nurse came, a quality nurse of the hospital, who told that there has been skin injury in the unit for the past 6 months. So you need to review the data. He has been maintaining a register where he has been documenting the skin injury data for the past 6 months. But you did not know that there is so much of babies, 10 babies who have had nasal injury in the past 6 months.
Recording in progress.
Okay. So first of all, to identify the problem, we need to review the data. Here, the QI nurse is having a register where you are going to review and find out how many babies are having nasal injury. The second thing is there are many problems in the unit. Like myself, Dr. Usha, I pointed out in the role play that in this very preterm baby, my consultant asked what all could have been done better. I told that TPN could have been started. I told echo machine was not there. Echo could have been done on day 1. An ideal thing I told, we could have prevented preterm birth itself so that all the problems can be avoided. We need not do work and babies will not have any morbidity and mortality. These were the problems which I felt was important in that baby. Then what happened is nasal injury. That was finally found out, which we all missed in the baby. Then, so we have found out nasal injury is a problem. Then how to form a team and what is our aim statement. Our HOD sir asked what was the aim statement for Dr. Sarath to do his thesis. He told that he is going to reduce the nasal injury
not
from...
able to see or we're not able to hear, ma'am.
Yeah, can you hear me? Dr. Amulya, can you hear me?
Voice quality is not good.
Yes, sir.
Your voice quality is not good. There is some problem, technical problem.
There is some echo, sir. Is it now clear? Sir, Dr. Amulya, is it now clear?
Yes, ma'am, it's still very not heard very properly, ma'am. It's actually I think there's a lot of echo or it's very shrill, like a lot of disturbance.
Okay.
Recording in progress.
Ma'am, when you're talking on the phone, I think it is better, ma'am.
But it will be heard in this. So we have to speak only here and do it only through this. இதில் கனெக்ட் பண்ணுவோம் ஸ்பீக்கரில்.
1 minute, please.
ஸ்பீக்கர் அவுட்புட் எனக்கு வரும்.
Is it better now? Is it better now?
Yes, ma'am.
I'll talk straight away from me. Okay. Is this better now?
Yes, ma'am, definitely better, ma'am.
Yeah, okay. Oh, first of all, we need to. Sir, mute agam. It is not simple. We need to give a proper antenatal care. it is ideal, but it is a long-term project. We cannot solve it by sitting as a team of 6 or 8 members, and it is a long-term project. It cannot be taken as a QA problem. Next thing is, it should have this problem. If you solve this problem, it should be significantly impacting the patient outcome. I didn't do echo, I didn't start early TPM, but the baby is hemodynamically stable. It has not affected the outcome of the baby in any ways. 12 hours I didn't do echo, maybe I will do today. It has not affected the outcome till now. Baby has developed a nasal injury. Already there is nasal injury. Maybe baby can have long-term cosmetic deformity also. So it is going to have a significant outcome. Does not need any new resources. You need not, to address the simple issue of nasal injury, you need not recruit so much of nurses, you need not buy a expensive equipment in order to solve the problem of nasal injury. Next slide please. So we need to identify a problem which is fitting into all these criteria, and it is not a rare event. Suppose I am doing ECMO for a baby once in a year. I cannot identify a problem where to decrease clotting in the ECMO circuit. I cannot identify that problem to be taken up for a QA study, because I am going to do ECMO once in 2 years or once in 1 year. So implementing that might not have significant impact on my unit baby's outcome. And next thing is short turnaround time. So if this you do for the first 2 days when the baby is on CPAP, if every shift you are checking, if you are putting an appropriate mask, yes, you can see the outcome. By the time you remove CPAP, you can see whether there is nasal injury or there is no nasal injury. So it should have a short turnaround time. Your change and the outcome should have a short turnaround time, so you can see whether it is working, whether whatever change you have implemented has improved the quality of care of your baby. So next is avoid long-term projects. Again, same thing. Decreasing hemorrhagic disease of newborn. So if 10,000, 5,000 babies are getting vitamin K and some 500 babies or 2,000 babies are not getting vitamin K. In order to see a hemorrhagic disease of newborn is developing or not, you need to have such a large population. Maybe 1 year babies you need to check and you need to see. Maybe some 10 babies I missed vitamin K. Rest all 890 babies I have given vitamin K. Is there any one case of hemorrhagic disease of newborn which has developed? So that much population we cannot address in a short time, and QA might be inappropriate for a long-term project like what I told before, prevention of prematurity. So this QA might be inappropriate for a long-term project. Next slide please. So we need to identify a problem which is fitting all these criteria. Resources should be limited, it should be simple to address. What we can see is the next slide will be showing the NICU chart of very preterm babies. I know that many PGs have joined here. So you can put your answers in the chat box. There are many things this NICU chart is showing, and I have tabulated those things. Okay, so plastic wrap, there are 10 babies. We are seeing the NICU chart of 10 very preterm babies born below 32 weeks. It is showing whether plastic wraps used in delivery room for thermoregulation, whether baby was transported in incubator to NICU, what was the admission temperature of the baby when the baby arrived to NICU, and whether baby had respiratory distress after birth, whether baby was started on only CPAP, whether baby required mechanical ventilation, whether baby required surfactant. So these are the things which I am taking from my NICU chart for the 10 babies who have been admitted in the past month. So next slide please. So there are some processes happening and there are some outcomes of care here. So in the care given to this very preterm baby, the table columns, some of the columns are processes of care. Some of the columns are showing outcomes of care. Okay, now can you go to previous slide? So you can put in the chat box what are the columns, headings which are showing processes of care, and what are the headings which are showing outcomes of care in this very preterm babies. Process of care. First you can put what are the process we have done in this very preterm baby. Maybe you can type in your chat box. We cannot hear your voice, so you can type the answers in the chat box. term baby. Okay.
Second, transported in incubator to NICU.
Transported in incubator or not, that is the process of care.
The temperature is taken at the time of admission is again a process.
Can you hear now? Can you hear now? Yeah. Okay, I'm here. There are some processes of care and there are some outcomes shown in the table columns. So what are the processes of care in babies? What are the outcomes in the baby we have seen? Can you see the table and tell, first of all, tell what are the processes we are doing in this baby? You can put your answers in the chat box. Or you can unmute and speak also. Plastic wrap, yes, here also participants told clearly that the putting a plastic wrap will be a process of care. Then, using a transport incubator, shifting the baby in the transport incubator is a process of care. Next. Initiation of early CPAP is a process of care. Very good. So what are the outcomes of care we are going to see? We are seeing in this table from this NICU chart. So admission temperature, whether baby is hypothermic or normothermic, it is shown in the column. That is the outcome of care. Okay. Next. Need for mechanical ventilation and need for surfactant are outcomes. Okay. So now we will see the what is the percentage of babies who have received this process of care. So all babies are less than 32 weeks. How many among less than 32 weeks? 1, 2, 3, 4, 5, 6 babies have been wrapped in plastic wrap after delivery. So what is the percentage? 6 divided by 10. So 60% of the babies have received plastic wrap. So transport in incubators, can you tell the percentage? 40%. 40%. Very good. So if you take the outcome, so we'll take an important outcome like admission temperature. So can you tell how many babies were hypothermic? 50%. 50%. So 50% of the babies we have marked a temperature which is fitting into hypothermia. So this is how we have corrected that only 60% of the babies are receiving plastic wrap and 40% are transported in incubator and only 50% of the babies are normothermic and 50% were hypothermic at admission. So these are the problems we have identified. Maybe you can check. Early CPAP was initiated only in 40% babies, but on babies with respiratory distress only we are going to initiate early CPAP. So denominator will not be all the babies. Denominator will be babies with respiratory distress. So 1, 2, 3, 4, 5, 6, 7, 4 by 7. So it will be slightly higher than this and around 60% it will be. Okay, early CPAP was initiated in 58%. Initiated in 58% of the symptomatic babies. So this is how you interpret your hospital register, either perinatal, either a neighbor room register or your NICU chart. This is how we need to extract data and we need to find out what are the problems existing in our unit. Just telling one person resident is telling staff is less, we are not doing that, many babies are hypothermic. We need to quantify. Is it really a problem? We need to go to our data and find out what is the percentage of these problems. We need to identify all the problems in that specific area. Either it is NICU or labor. Next slide please. Next slide. Next slide. So we have seen percentage, performance percentage. Next slide. Next, outcomes for percentage also we have seen. Okay. So now we have identified all the problems. I am not using plastic wrap, I am not transporting in, we are not transporting in transport incubator, we are not starting early CPAP for symptomatic babies. So babies are hypothermic, so babies are requiring surfactant, so babies go for invasive ventilation. All these things I have identified as problems. And we cannot start giving for all the problems together. We need to prioritize which problem we are going to address maybe early CPAP, if we start surfactant could have been prevented. Giving need for surfactant could be prevented. So I feel that that is the most important intervention. It should not be a personal opinion. We need to work as a team and decide which problem is has a more priority than the rest of the things. So these are, suppose these are the problems we have identified. Hypothermia at admission, and another aim is to decrease the need for ventilation, to decrease the need for surfactant. So the problem should get a maximum score in terms of all these entities. Like it should be very much important to patient outcomes when compared to other problems. It must be very much affordable. It should be easy to measure. Like what is the admission temperature? It is easy to measure. Number of babies who receive surfactant, number of babies who did not receive surfactant. So it is also easy to measure. It should be under the control of team members. Okay. So, sir, Dr. Amulya, what do you think? Which aim will be having more priority out of these three?
Decrease in the number of babies with hypothermia.
Very good. Very good. Because it might be more important to patient outcome because admission temperature will increase the mortality and plastic wrap is not so costly. Yes. So, and maybe it will be affecting baby's outcome and temperature is easy to measure. And okay. So, Amulya is saying by stabilizing delivery room temperature itself, delivery room temperature and stabilizing the baby's temperature in the delivery room itself can prevent hypothermia after admission. That also is very simple to do. So, and it has a major impact. So, I will go with the, yeah, okay. Very easy. Very good. So this will be getting the maximum priority, maybe a score of 19 and 20. So we have prioritized and we are taking that problem as the QA initiative. And now that we have decided, yes, I need to increase my admission temperature. Admission hypothermia at admission should be decreased. This is my primary problem. This I am going to address by using a QA initiative. Okay. So next we need to form our team. Team members should have all the people, right from top level to bottom level. All the category of people should be in the team. And we need to look for volunteers. We should not, like our thesis, we should not pull someone into the study. They should be volunteering and they should be very much enthusiastic to be involved in the study. And they must be involved in the baby care. They must be either in the labor room or NICU, or they must be a resident or consultant in charge, whoever, or a biomedical person who is in charge for maintaining a transport incubator, all those things. So these people should be involved in the baby care in some point of time, and they must be influential. So the staff or nurse whom you are selecting must be able to tell to other sisters and convey that maintaining temperature is very important. These changes we need to do, how important it is, because it is going to affect the baby's outcome. This every shift you need to follow this. So she must be capable of convincing the other team members. And from every level we have selected our team members and we need to assign key roles like leader, communicator, recorder, who is going to record how many babies are coming with hypothermia and what is the sequence of events that is happening, and he is going to record during every team meeting. First the team will meet, know what is the problem and how to form a aim statement. Our HODs have called Dr. Sharath and myself to ask that how are you planning to decrease the nasal injury? What is your aim of the study? What are you going to do for your thesis? So that's how the team members will meet and they will decide. So what are they going to do? All these team meetings, process, whatever has been concluded, whatever change you are going to implement has to be recorded. So why teamwork is important? Because it involves all the people, and sometimes a consultant or resident might not be able to identify grassroots, ground level problems, like what are the problems staff is facing. There is a non-availability of plastic wrap itself. If you take this problem, there is non-availability of plastic wrap. Sarah's told that we need to sterilize the plastic It is not our responsibility to have a plastic wrap in the labor room. So what are the problems? Where is the resistance, either in the labor room or during transport or in the NICU? That also we need to identify. That maybe a junior resident or staff might be able to easily point out. So only we need to have all these type of members in your team. And more participation means all these inputs who will give. The sister or resident who is going for delivery call will be able to give to HOD than a assistant professor or a person at a higher level. And when we accomplish things together, let's say we are able to reduce hypothermia, it will build the confidence of all the team members as a team, and we will be able to do more to improve the outcome of the babies. Finally, like what sir asked, what is our smart aim? How are we going to address our QI problem? So it is not like another research study. In another research study, we will have PECO or PICOT format, PICO format to write the objective. Whereas in a QI, it is a smart aim statement. Smart in the sense, S stands for specific. Specific problem. What is the problem you are going to identify? And it should be measurable. Easily, temperature is, there were 10 babies with hypothermia. Now temperature I have recorded this month, no baby is as hypothermia. And it should be achievable. You must be able to achieve that. And it should be relevant to the problems which are existing in your unit. It should be realistic and it should be time bound. Okay, hypothermia is now baby is coming from the delivery room to the NICU. Your process ends, and NICU you are measuring a temperature. So it is very much time bound, and also time bound in the sense if you are going to reduce hypothermia to 10% or to 5% in your unit, by what time you will be able to achieve? What time period, either 1 month or 2 months, what time you will be able to achieve this target of 5 or 10%. By 1 month I will be able to achieve this, and I will be able to say that all my babies are normothermic at admission. So what is your time frame for implementing the change and improving the outcome? Okay, so it should be specific, measurable, achievable, relevant, recorded, realistic. It should be timely. You cannot take a neurodevelopmental outcome which you are going to assess in 3 years, 4 years. That cannot be taken as a QA project. You need to mention your time frame by which time you are going to achieve the decrease in hypothermia to a specific level, either 10% or 5%. Okay, so this is an example. We prioritized our problem. No? Our problem was hypothermia at admission. I saw from the register that it was 50% of the babies who are coming with hypothermia. So I wanted to specific is percentage of babies with a low temperature, and measurable. Measurable in the sense, yes, temperature less than 6.5 degrees Celsius. Achievable. Yes, it is achievable by simple interventions. Since hypothermia can be prevented. It should be relevant. Yes, it is very relevant because NICU has so much of load. Admission temperature is going to increase the mortality. It is very much relevant to my unit, where 50% of the babies are having hypothermia at admission. And timely. So between 15th in 6 weeks, from 15th December to 30th January, I will implement the change, and by 30th January I will decrease my hypothermia to less than 10%. So these are this is an example for smart aim. So here they have put a aim statement, like our aim statement, which we told to our HOD to establish skin-to-skin contact after delivery in low-risk mothers who are admitted in labor room. So is this a good aim statement? No. We have not told from what percentage to what percentage we are going to improve, and by what time, either 1 month or 6 weeks you are going to achieve this 100% skin-to-skin contact or 90% skin-to-skin contact. So next statement gives the aim statement in the smart aim format. So to establish skin-to-skin contact after birth for at least 1 hour from 0%, which is existing at present in my unit, to 50% within 4 weeks. Okay, so this is the ideal aim statement. So thank you. We'll go on to the next continuation of the. Any doubts you can put in the chat box, please. Or you can unmute and answer as well. Is it audible now? Is it audible now?
Hello.
Yeah, you can unmute and speak. Is it audible now?
Yes, ma'am.
Okay. So any doubts, you can unmute and ask, or you can put in the chat box as well. Okay, we can move on to the continuation of role play. We can finish it off. Now that, sir, we have attended the... Yes, sir. We have attended the QA workshop, sir. We went and attended how to write a aim statement, sir, and we understood how it should be written for a QA, sir. Sharath, you want to tell?
Sir, we heard the talk of how to create a smart aim. So now that we understood that we need a team to establish. So we'll start off with our skin nurse also to be involved, and our staff nurse to be involved, and my senior to be involved. If interested, even the consultants can get involved into it, because QA is a continuous process and everybody has to learn. And also initially when I thought I'll bring it down to 0, that's a very unachievable aim. Probably I'll put it down to say from 50% that is currently according to the skin nurse, we'll try to bring down to around 20 or 10%. So we'll fix the aim at probably 10%. We'll try to bring down to 10% and within 3 months. So we'll follow up this study through, and we'll see if we can do that. And I'll request the staff nurse to share data with us, just not to look at the baby and not giving out the data to the unit and giving it directly to the QA team, because the stakeholders are us, and we would like to see if we can change the process here.
So very good. So, so you have already formed a team, and the team consists of everybody who's going to taking care of the baby, and then you formed a smart team. So specific aim is, in the aim, specific is you're reducing the nasal injury, and then measurable is
From 50 to 10%.
okay, achievable.
It is achievable. We think it is achievable, sir, by proper care.
Is it relevant?
Yes, sir. So many babies have had a nasal injury. Skin nurse is telling so many babies have had nasal injuries. 50%.
And time bound. It's like timely.
We are thinking by 3 months
We should be able to.
achieve, sir.
Right. Thank you. Is there any other questions you like to ask, Doctor? Thank you. Thank you. Okay. Yeah, we'll start the game. I think the game we have to be part of the team anyway. Yes. Yeah. So what we'll do is, in the meantime, I'll try to rectify this. என்ன பண்ணலாம்னா, இது இந்த வால்யூம் இந்த ஸ்பீக்கர் வால்யூம் கட் பண்ண முடியுமா? ஸ்பீக்கர் வால்யூம் மட்டும் கட் பண்ணுங்க. Don't want speaker, I don't want it. Speaker volume reduce. No, but then we won't hear them well, yeah. Okay, then slight volume, little volume. Yeah, can you hear us?
Able to hear us?
Yes, ma'am.
Is it clear? Any echoing?
Minimal, ma'am.
It's working. Okay. Now we are going to play a game. So if all of you had been here as offline, we would have had all the delegates also here, because now it will be by the faculty team and also mm, by the participant. Okay, so basically the rule of the game is from this is a stick, so you will be bringing from up to down till the chair. So all of you can participate, please. Okay, so you should never remove the finger out of contact with the stick. Down. It should be, you should be bringing it down, and all the time your finger should be in contact with the stick. It should never lose contact. All right, shall we start?
Shall we start?
Out here,
It is
sir.
very difficult, sir. It is very difficult.
So what have you observed here is all of them are trying to bring down the stick, this thing, and then so what is that is happening? Why are you not able to?
Maybe we are lacking a team leader here. We are lacking a team leader. Sharat, do you want to be the team leader so that we can listen to you? So now, like, we are just going to follow what Sharat says. Okay, no one is going to do anything other than what he is going to say. Okay, and not do anything. Okay.
So what we'll do now is we'll slowly start bringing the stick down. So it is tilted onto the other end. So we'll start bringing down from the other end. Slowly, slowly, slowly. Keep in contact with the stick. Ashok sir, you can start bringing it down. Uma ma'am, you can also start bringing it down. Usha, please bring it down carefully. Again, another 5 centimeters down. You can still bring it down. It is being balanced. You can still bring it down. Some more. Bring it down. Some more. Some more. Some more.
So good, you have reached the target. Yes, very good. So appreciate the team. I think, so what have you observed here now is that before that, you did understand the purpose of this game is that before the thing that, they tried to bring it down, each one was not having any idea. So they were doing it on themselves, to, bring it down at their own idea and at their own pace. So that's the reason why the stick we could not keep the stick in a horizontal position. So that's the reason why the stick fell down. After, there was a team leader who was actually directing everyone what to do. And everyone was just following the, instructions from the team leader. And once you keep following the stick, you could bring down the stick as planned in the beginning of the program. So that's this, stresses on the importance of teamwork, which needs, a leader, and you need a plan, and so that to execute it. So this is what we are going to see, from now on. How are you going to plan, and who's going to do what, and things like that. Okay, now next lecturer. Next is. Okay, now will be the hands-on session. So what Dr. Uma would elaborate on how you.
Chat box. So basically, basically we want all of you to enter into it's there in the chat box. You can click on the chat box. So you can click on the chat box. That will make you enter into this POCU website and register yourself. Okay, so if you click on this online POCU certificate course, all of you are following. I hope you are following. So you can enter your email ID and password if you have already registered. If you have not registered, you can register or you can continue as guest. You can continue as guest also. They won't get certificate, they can continue as. So you can continue as guest also. So all of you could do that? Have you? So you can unmute and speak if there is any problem. Um, okay, so Dr. Amulya, Dr. Vikas, and those who are there in the joined online, Shamini, are you able to reach till this step? You can put in the chat box whether yes or no. Have you reached? Okay, okay, sure. So, good, good. So, actually, you can give your laptop to him or he can do it from here itself. Okay, so we are clicking on this learn 4 steps of care. Okay, so that will open up this page of step 1, step 2, step 3 and step 4. Sharat, he can do this only. Maybe he can do this only. You can. Okay, so we are going for the step 1 now. I think someone is talking. Can you please mute Monica? Mute பண்ண முடியல. No. Okay, not able to. Okay, so you want to start? You can start identifying the problem.
Should I speak?
No need. You just have to do yourself. Just. Okay, hope Amulya and other delegates are also doing.
Yes, ma'am. Ma'am, do we enter and press the next button?
Yes, enter and press the next button. You'll get 4 steps of identifying the problem, etc. So click on to that step 1. This hands-on session will be only on step 1.
Okay, ma'am. Okay, thank you, ma'am.
This one? Step one is identifying the problem. Should I?
Ma'am, we answer the questions, ma'am.
Yes, you have to. That is a learning. Step one is a learning objective. So, how to
Okay.
review the data, how to prioritize, how to form a team, and how to write a clear aim statement.
Okay, ma'am.
Out of which, like we have come only up till yeah, up till till
How to write
identify.
a clear aim statement.
Yes. Okay. So you can read for yourself. You work in a district hospital of 2,000 babies annually. A single nurse works in the labor room, and a nurse in charge is there as well. And a doctor manages the labor, but they do not have like blood bank facility, so they cannot handle emergency. So usually babies and mothers are kept and they are discharged at 24 to 48 hours. So they have huge lot of data and they want to look into their data how it is. You can go to the next. Here, this is the data which they have out of the 10 patients who have come. They have collected a few of the data. On your left hand side, you are getting the question Q1 and Q2. So, what you should be doing is you have to answer that Q1 and Q2.
Ask one person to share screen.
Okay. Next, he can do it. He can do it for this.
So, doctor.
Processes and Apgar score and
Okay,
temperature.
there is a icon here, P and O. So you can click on. You think this is a process or an outcome?
Which ones, ma'am?
This one, giving uterotonic given at 1 minute. Is it a process or outcome?
Process.
Okay, so it's a process. You can click it. Like that, you can go on. Um, so, here we have done some process and outcome. So you can continue. This is a process or outcome. Okay, Dr. Amulya, like, are you agreeing with? Did you also get the same thing, Dr. Vikas, Dr. Amulya?
Ma'am, I'm not able to down. Oh, it's not opening yet. It's still loading.
Okay. What about others?
Ma'am,
Yes.
unable to load, ma'am, still loading. Yeah.
Anyone has got up to this stage? Anyone has come up to this stage?
No, ma'am, I have not yet reached, ma'am.
Okay, anyone? I'm asking who has reached. Dr. Vikas, Dr. Shamni. Okay, you can go to the next step. That's fine. You can go to the next step. Okay, so you just have to calculate the percentage performance and fill it. Have you reached this stage? Like anyone from online delegates? Amulya?
Yes, this is Dr. Vikas. Yes, we have
Yes,
reached, I
yes.
have reached.
Okay, okay, good. I think it's more of self-learning. If you have any
Yes, yes, yes.
queries, you can always ask us or interact with us. We are there.
This is the scene what the Skinners was doing. These are the data which weight வரலாம், birth weight வரலாம், gestation age வரலாம், and injury type, degree of injury வரலாம். அது சொன்னீங்கன்னா இது கோலேட் பண்ணுவாங்க. அதை போடுங்க. ஃபஸ்ட் எடுத்து சொன்னல, if you relate to our scenario which we started, prevention of people.
Okay, just can go through. I think hope the delegates online, sorry, we are not able to actually see you. We do not know what you are doing. So hopefully you are in some of these, one of these stage.
Yes, ma'am. This is Dr. Vikas.
Yeah,
It's going nice.
yes.
No issues.
Sure. Thank you, thank you. If you have done with it, you can go to the next. Are you okay? Like you have understood the concepts and other things. Okay, so this is again a kind of self-learning. Others, have you come to this stage? Dr. Vikas has identified. Amulya,
Ma'am, I'll just get back, ma'am. I'm trying it on another system if it's possible.
okay. Dr. Raj. They are going to do the hands-on. I think what we thought is if you are going to get delayed on that, we can kind of do simultaneously when our delegate is doing here in the offline workshop. So we can kind of discuss on things so that we can kind of complete together. Is that okay? Amulya and others. Rajpal Singh. Sir. Hello, sir. How are you, sir? QI, sir.
QI, very good. Online you have people?
Yes, sir. We have some.
Very good. Well done.
Thank you, sir.
QI is the thing. I think if QI is inculcated, the care will definitely improve. Isn't it?
We can just say, we just came to say hello to all the faculty.
Already proved that many of the neonatal mortality is not because of non-utilization of this thing, but lower care of level of care, quality of care. Thank you. Thank you. All the best. Thank you.
Meeting host will let you in.
It's not the host. He has called.
Ashok Kumar, some co-host.
Yeah, we are just. Yeah, okay. We are just giving time for you to just fill in up. We lost the net connection. We are just reviving it. Can you please keep doing that? Keep doing that. Have you completed step 1? Till reach till smart aim. So you can keep moving on and you reach smart aim. Complete step 1. You can go on to complete step 1.
Recording in progress.
Okay, so in this particular chart, it basically asks us to identify what is it important, is it affordable? Dr. Usha was insisting on all these factors repeatedly. So is it important, is it affordable, is it easy to measure, is it under the control of team members? Say, for example, if you take here immediate drying, definitely it is important in terms of the process. It is a process. It is not important to patient outcome as such, but definitely that process is important. That process we are actually doing to make a better outcome, namely decrease in the temperature, low temperature at 1 hour. Okay, so to prevent hypothermia, that is a process which we are doing. It may or may not be as such important to the patient, but it is important as a process. Whereas if you take the other things, namely like affordable, yes, immediate drying is quite affordable, it is easy to measure, and it is under the control of the team. So if I'm taking one more example here. If you take the last example, decrease in low birth weight less than 2,500 grams. It is a aim where even globally or internationally they are not able to achieve. Okay, so basically, so that one, it is important to patient outcome, but it is not under the control of team members. Though it is easy to measure, in terms of affordability, in terms of time and resources, it is not possible. So basically, if you have identified many problems, in our mind, we have to prioritize in terms of whether it is it important, is it affordable, is it easy to measure, is it under the control of it. There is no correct or wrong answer to any of these things, but generally speaking, you have to see what is directly under control and what is important in terms of patient outcome. So, being a like website where you can access anytime, we request the faculty team request all the delegates to do in your own pace and complete this task of all the 4 steps. We'll try to have some hands-on session in between, but now we are moving to the next step, namely one more game. Yeah, you can put it last one and then we can move on. Okay, basically, is it important to patient outcome? Yes, maybe like to the outcome it is important, but it is not affordable in terms of time and resource. So you will place a lesser number for in terms of affordable in terms of time and resources. It is easy to measure because birth weight is a measure which only weighing machine is needed. So yes, it is easy to measure in terms of measurement as such. But maybe under the control of team members, no, it is not at all under the control of team members because reducing the low birth weight, so we can give some 2 or something. So each and individual stem you will be seeing how important it is to patient outcome, how affordable it is, and how is easy to measure, and whether it is under the control of team members.
It is like prevention of prematurity, prevention of low birth weight babies.
Yeah.
So it requires a long-term project with many members, maybe national or local projects.
Okay, choose a gap which one do you think should be done immediately? Maybe immediate drying, delayed cord clamping, okay, and anything you can choose. It depends on like what is your priority.
Probably temperature will have a long-term impact, will have an impact, more impact on the outcome because mortality and morbidity it will affect. Yes, delayed cord clamping, immediate drying as a process measure is also important. But if you're not able to maintain temperature itself, then we cannot go to other intervention like delayed cord clamping. So temperature is of more impact than the other things. So I think that important to patient outcomes, we can put 5 for low temperature only when compared to others. Maybe other outcomes might be little lower impact on patient outcomes. It might get some 4 or 3 according to your unit setup. If everything is already perfect in your unit, then delayed cord clamping may be 5. Already temperature, if you are not able to maintain, that will be the priority for that measure, patient outcome measure. So maybe that will be getting 20 marks.
Okay, fine. I think we are going to move on. I request all the delegates to enter into this and complete this task in your own pace at home. Okay. So we are moving on to the next session. We want you here. Okay. Stopping. Yeah. I'm stopping because you can do it later. Other delegates online, we are kindly complete this task at your own pace. And there are like many explanations given in this POCU website. So I think it is more of self-learning. So we are moving on to the next session.
Game. So now we'll see the importance of communication and how communication passes on from one person to another. And your QA is basically communication. If you can communicate from the top level to the bottom level, that is how you manage your QA. So if you do not, if your communication starts failing in between, the final outcome would be totally different from what you have expected. So let's see how this pass on game occurs. So we'd request our delegate to also come. So I'll just explain how this works. So we'll begin. So Dr. Usha will give a shape or something, and she'll inform Dr. Uma about the shape, and Dr. Uma will be writing on the backs of each of us. So finally,
Writing on the back of
the person in front of them, and finally our doctor will be drawing it on paper to see what has come out. So we'll let us look at the outcome.
Actually, they are trying to draw the shape in each back. So they are not speaking at all. Each one is drawing on the back of the person who is standing in the front. Finally, the first person is going to draw and show what the last person is going to draw and show what the first person intended to, what shape or shapes drawn.
So what was it?
So I told elephant.
Zoom it on.
Actually, elephant was told.
He has to zoom on.
Elephant was told to the person, the initial person, and
It's okay, it's okay. You can stand there.
One person is trying to draw hippopotamus and another hippopotamus and another person has identified it as key and another person some letter. Finally the person has drawn letter A in the notepad, the final person.
So what you understand is putting in the right method to.
So what do you? Actually doing the groundwork. Say for example, if it is not able to hear. Sorry.
Am I audible? I think it's audible.
Dr. Amulya.
Yes, ma'am. Now, ma'am.
Yes, yeah, sorry. Actually, what we are trying to get across is the communication should percolate and it should reach till the end. Say, for example, even in that CPAP injury session, if we think that the CPAP injury should be prevented, the nurse who is taking care in the bedside should know like what the team is planning, and it should percolate in the same manner. The same pace should be percolating into till the end. Sharath, you want to add on? Okay, so
You can also say you use the right method of communication also in this. And also when anything you use, you should have the right method, so that probably, to communicate, that elephant to entire the team, probably we could use hearsay, like, probably we could have whispered on to every ears, probably everybody would have understood this instead of drawing. So drawing is not the right method to communicate in this scenario. So like that, the same rule you should apply in your QA project to analyze and do your methodology. So next I invite Dr. Raja. So
communication basically it should
communication and the right methodology.
yeah, intend to say till the end. See, team might be saying so many about the nasal injury, but actually it should ideally go into the final person who is taking care.
Okay, so we will move on and we invite Dr. Raja. He'll be talking on the step 2 of quality initiatives.
It's okay. I'll ask for the slide to change. That will be fine. This is not working. No, it's not. Right. So are the slides visible to all the delegates, online delegates?
Not yet, sir.
Not yet. Okay. Let us check. I think we have to share the screen. Okay, before we have the slides with us, so far what have you learned? So you have come across a problem, so you have identified what is the problem. So from the problem you have prioritized that what problem you are going to work. Then you formed a team, you selected the team members, and in the team members you clearly allocated roles to the team members, and then you have formed a SMART team. Okay, so SMART stands for specific, measurable, achievable, relevant, and in a specific timeline. So are the slides visible now? Okay, you have not yet.
No, sir.
No.
Yes, sir.
Okay, thank you, thank you. So, can we go to the first slide? Okay, so we have reached the step 2 of quality improvement workshop. So this step deals with analyzing the problem. Myself, I am Dr. Raja Ashok. I work as a neonatologist at Anu My Baby Hospital, Vijayawada. So the next slide. So all the slides which I am presenting, they have been adapted from the POCI guide. They are available freely online at pocqi.org. So you just have to listen to what I'm speaking. You don't have to take screenshots or notes. So the next slide. So at the beginning of the QI session, we discussed that there were 4 steps of QI. So far we have identified the problem, we have prioritized on what problem to work at, we have formed a team, and we have written an aim statement. So in this step, we are going to analyze and measure the quality of care. Next. So what are we going to learn in this session? So we are going to learn the tools for understanding the process and systems of healthcare, and we are going to learn how these tools can help you identify the possible solutions to reach your aim. So why is analysis important? So basically, for example, if you are sitting in an OPD and you are treating a case of fever, you are basically just not treating fever. You are not worried about the symptomatology, you are worried about the etiology. So the same thing applies for healthcare and quality improvement also. So when you analyze a problem, you want to reach, you want to reach about what are all the causes that lead you to the problem so that you can address them. So analysis is a very important and integral part of quality improvement initiative. So you have to explore, so analysis lets you explore in detail all the possible causes of the problem that you have identified, and it helps you focus on what are the problems that are within your control. So these tools that I'm going to discuss, they are going to give an opportunity for everyone in the team to contribute to understand what exactly is the problem. And it helps you understand, that is, what is happening with the system at present and what are the possible solutions that can be identified. So I'll be discussing 4 tools for analysis. They are the fishbone, the 5 whys, the Pareto principle, and the process flowchart. So the first tool that I'll be talking about is the fishbone. So fishbone allows you to identify all the possible contributing factors that are leading towards a problem. So why do you get this name as a fishbone? So fishbone, because once you draw this diagram and once you have completed analyzing using a fishbone tool, fishbone literally means the skeleton of a fish. So when you, in the next slides, we would be seeing that once we put on the diagram, it would basically look like a skeleton of a fish. So fishbone analysis is basically categorized under the following headings. So we broadly have 4 headings under fishbone analysis, and these broad headings are basically the levels of healthcare, the systems of healthcare. So who are all involved in healthcare. For example, you have people, you have places where you are working, the procedures or the practices that you are following, and the policies. So in people are those who are involved in providing the care, so which involves doctors or nurses. So these people may not know what they are doing, what is the correct method of doing it, or they might be doing it wrong. They in fact might not have formal training of what they are doing. So this is a system of healthcare. Next thing is the place where you are working. It may not be conducive, or you may be unfamiliar with the place. It may not have the proper equipment, so that might affect the quality of care to the patient. Next is the procedure or the practices that you are doing. So the practices or the procedures that you are doing, you might be doing it in the wrong order, or you might be repeating unnecessary steps that is contributing to poor quality of care. And next, the policy. The hospital may not have a policy at all about the problem that you are working about. So these are the 4 basic headings of a fishbone. Next slide. So
how do you draw a fishbone analysis? So in a fishbone analysis, once you begin drawing it, so to the right side of your, the previous slide, to the right side of your paper, you must first write down the problem, and around the problem just draw a triangle. So this represents the head of the fish. So the problem is on the right side of your screen, and that resembles a head of a fish. From the head, you draw a horizontal line, that is basically the spine. And from the spine, you have again lines which are coming out from the spine. And all these four that I have discussed, the categories, the policy, people, place, and procedure, these are the systems of healthcare. So from these lines, again, you have other lines coming up. These are basically the bones of the fish. So I have labeled them as major influence and minor influence. So for example, if you have people contributing to a problem, so one of the major influence in the people is that they have no knowledge of the procedure that they're doing. Sometimes you identify quite complicated causes. So in them you need to also put in minor influencers. So in the next slide, I'll try to give an example and try to make you understand better. So this is a fishbone analysis for a QI project which tried to address the issue of delay in initiation of feeds after LSCS. So to the right side of your screen, what you can find is the head of the fish. And there they have clearly written the problem that there is delay in initiation of feed after LSCS. So what are the four systems of healthcare that we have discussed? People. So people, what are the problems with the people? Suboptimal awareness of the importance of early initiation, or lack of awareness about the possibility of change. So these are the problems with the people that are contributing to this problem. So what is the problem with the procedure? There are doubts in role allocation for the feed initiation. And people tend to forget about feed initiation after cesarean. So these are the problems with the procedure of the thing which we are trying to address now. So similarly with place, there is lack of information in OT for feed initiation. So, and also there is lack of proper recovery room with privacy for the mother. So the place where the mother is being shifted, it is not conducive for breastfeeding. So there is also policy which is contributing. So there is no clear policy that states that feed has to be initiated within 1 hour after delivery. So by drawing a fishbone analysis, we could list out all the possible causes under the 4 headings that I have discussed. So this is how a fishbone works. Okay. So next we move on. We move on to the next tool that we are going to use. It is called the 5 whys. So this 5 whys helps you understand why something is the way it is. Okay, so what you do in 5 whys is you pick up a problem and you start asking why until you reach the root cause. So to give you an example, there is a unit which is trying to improve the breastfeeding rates within 1 hour of delivery. I will take the same example as previously. So just keep asking why till you reach a root cause. So the first why, mothers are not breastfeeding. Why are they not breastfeeding? Because they feel uncomfortable about taking their gown off. So why are they feeling uncomfortable taking their gown off? Because the hospital has a gown which opens at the back. So they have to take the entire gown off to breastfeed. So they feel uncomfortable. So then you ask, why do we have this type of gown? So the answer is, this is what the storekeeper orders. So why does the storekeeper order this gown? Why doesn't he order better gowns which are suitable for appropriate breastfeeding? So because no one has requested him to do that. So because of this tool, you have now understood that the root cause for this problem is that the concerned person hasn't ordered the right type of gown. So you can take action on this and you can see the result. So that we would be discussing in the subsequent sessions. Next slide. So the scenario that I have described, it may be different in your hospital or it may be different in another setting. So, and sometimes it's not necessary that you ask why 5 times. For example, in this alternative scenario, the question why was asked only 4 times and we have reached the answer. So mothers are not breastfeeding. Why? Because they feel uncomfortable taking their gown off. Why? Because there is no privacy to breastfeed, so they feel exposed. So the problem in this scenario is not about the design of the gown. The problem in this scenario is with the place. The place is so designed that there is no privacy. So the mother is not taking the gown and she's not breastfeeding. And also you have to note that we haven't asked why 5 times here. So 5 why, as the name mentions, it's not necessary that you have to ask the why 5 times. Okay. So next, the third tool that I'm going to discuss is the Pareto principle. So what is this Pareto principle? So this, yeah. Sure. Okay, no problem. COVID certificate. So, yes, yes. Okay, we can continue. So till now we have discussed what is fishbone and what is 5Y. So we have reached the third tool, that is the Pareto principle. So what is this Pareto principle? Okay, can we continue? Yeah, okay. So the third the tool that we are going to discuss is Pareto principle. So what is this Pareto principle? So basically Pareto is the name of a person. He was a Italian economist. So what he discovered, he was studying. Okay, again I'll begin from what is Pareto principle. I think there was a issue with the transmission. Now it's coming? Okay. So what is Pareto principle? To begin with, Pareto is actually a name of a person. Pareto was he was an Italian economist. So he was studying the economics of Italy, and he discovered that 80% of the wealth of Italy is held by 20% of the people. So the same concept when applied to healthcare and quality improvement, what we have found out that 80% of the problem is because of 20% of the causes. So if you can address these 20% of the causes, you are going to get 80% of the results.
So there is a lot of disturbance, sir.
Yeah, we are trying to change the laptop. The internet connection is restored. Just bear with us for 2 minutes. We'll do it.
Okay, sir.
Right. So, are the slides visible?
Yes, sir.
The audio is fine?
Yes, sir.
Yes, yes.
Okay. So, we are getting echoes. So, whoever is not speaking, kindly mute yourself. Okay. So, okay. So, okay, what's Pareto principle? So, Pareto is actually a name of a person. He is an Italian economist who studied the economics of Italy. So, he discovered that 80% of the wealth of Italy is held by 20% of the people. So, when we extrapolate this to healthcare and quality improvement, we have found out that 80% of the problems that we face is because of 20% of the causes. So if you can address the 20% of the causes, you can achieve 80% of the results. So the 20% of the causes they are called the vital few, and 80% of the the causes are the trivial many. So what Pareto principle tells you is that you have to focus on the important causes that you have identified to achieve results faster. So I'll explain this better by giving you an example, and we can move to the next slide. So this is an example of a a Pareto principle, medication errors. So this is a unit which is trying to find out the causes of medication error. So they have found out about 10 causes of medication error, like prescription error, improper storage, dilution error, while being labeled wrong, misused dose, wrong dose, expired medicine, and so on and so on and so on. So if you can see, prescription error, improper storage, and dilution error, these three causes contribute to 80% of the causes of medication error. So if you can focus on these vital few causes, you can address most of the the causes of medication error, and you can reach your aim faster. Next. Next. So this is how actually a Pareto chart is represented. So on the x-axis, what you have are the causes of the medication error. So as I have described, prescription error, improper storage, dilution error, so on, so on. And on the y-axis, you have the percentage of that error happening. So you have prescription error, which is happening 45%, improper storage, that is 20%, dilution error, that is 15%. The line that you see and the numbers on top of it, they are actually the cumulative frequency. For example, prescription error contributes to 45% of the medication error. So the second cause, improper storage, the cumulative frequency is 65, because 45 plus 20 of improper storage, 65. Dilution error, the cumulative frequency is 45 plus 20 plus 15, so 80%. So as you keep on adding up the cumulative frequency, you keep joining those lines, you form a cumulative frequency polygon. So this line keeps going up, 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 and it reaches the top. So after you make this, you have to draw a line from this 80% down. So when you do this, you realize that 80% of the problem of medication error is because of the first three causes, that is 30% of all the causes listed. That is prescription error, improper storage, and dilution error. So these three causes are the vital few. So if you can address them first, and if you can focus on these problems first, these causes first,
you can achieve your aim faster. So these are the vital few, and the rest are the trivial many. Next. So the next tool in quality improvement is process flowchart. So how does a process flowchart help? So process flowchart, by drawing a process flowchart, you are trying to see how a process is done or how an activity is being followed in your unit. So the best example for this is birth of a baby. So to start drawing a process flowchart, you must first identify what is the beginning and what is the ending. For example, if you're taking a labor room scenario, the beginning is the baby being born and the end is the baby leaving the labor room. So in between all this, you just list out the steps that are happening. So you identify the steps of the process as these are done at present. And then you just have to link these steps with arrows showing direction. So after you do all this, what you are going to see is you are going to review the steps that you have put in. So you are going to see, are you doing all the steps correctly? Are you missing some steps? Are you repeating some steps unnecessarily? Or do you have to reorder these steps? So by putting a process flow chart, you can identify all these problems all these causes to the problem that you're trying to identify. So there are certain rules on how to draw a flow chart. So the beginning and the end is always represented by an oval. Okay. So when you're doing an activity or a task, so for example, baby being born, that you put an oval and write it there. Next, putting the baby skin to skin contact. That is an activity or a task, or giving vitamin K, doing cord clamping. That is an activity or a task. So you just write that in a task. When you have to take a decision, for example, has the baby cried? Yes, no. That is a decision where you have to take. So those decisions you have to represent in a diamond, and all these shapes you will be connecting them using flow lines. So next. So again, the one thing what you have to remember is when you are describing a step, there is one arrow which is coming out, and when you are drawing a diamond or where there is a decision that you have to take, there are two arrows which are coming out which represent yes or no. Okay, the slides are visible. Okay, so when there is a step which is, audio is not there. Okay, is the audio audible? Is the audio audible? Okay, is the audio audible? Yeah, okay. So we were discussing about the rules of how to put a flow chart. So we know when to put a rectangle, when to put a diamond, when to put a cloud step. So what is this cloud step? I was discussing this. So cloud step, this you use whenever you are in doubt, or if you are unsure if that step is happening or not. Those kind of steps you represent with a cloud diagram. Okay. So for example, just to give you an example, I was discussing about the labor room scenario. So on the hands-on session, we'll have a better idea about how a flowchart, tries to help you reorder things so that you get better outcomes. So next. So the last slide. So analysis helps you identify several causes of the problem.
Sir, I have a doubt, sir.
Okay.
So like in our unit, we identified that hypothermia at admission was a problem, and we were not using plastic wraps, and we were not transporting in transport incubator in a substantial number of babies. So we don't know what to, we haven't done root cause analysis, sir, like what you told. Should we use this process chart, Pareto chart, fishbone chart, everything to analyze the problem? or what we should do,
So
sir?
each tool, so the question, okay, I think the question was audible to everyone. So each tool has its significance. So you, so the issue raised was hypothermia in very preterm babies and admission temperature being low. So for this scenario, the first thing I would like to use is, I would like to understand the processes which are happening. So the first thing I would put is a process flow chart. You know, so the baby is being born and the baby is reaching the NICU. So what are all the things which are happening in between? So then, so say, let's say the baby is being born. So after that, the cord is being clamped, the baby is being brought to the warmer. And then you are switching on the warmer. And then you have dried the baby. Then you are searching for a cling wrap. You have put the cling wrap. Then you have put the baby in a transport incubator. But you have realized, okay, I haven't switched on the transport incubator. You switch on the transport incubator and then you bring the baby to NICU and you realize that the temperature is low. So if you just analyze the steps that I have discovered, I have told. So you are doing everything that is being described in the book. So you are using a cling wrap, you are using transport incubator, you are nursing the baby under a warmer, but the order of doing the steps is different. See, so you haven't pre-warmed the linen, that you haven't switched on the warmer before the delivery. And after the baby, you actually don't have to dry the baby. You just have to use a cling wrap. And after you have put the baby in the transport incubator, you are then switching it on. So just by using this process flow diagram, you have realized that the order of doing things is wrong. And you have also realized that you are doing an unnecessary step of drying the baby. So you come to a conclusion that you just have to reorganize things to address the issue. So you don't have to have additional staff. You don't need any additional resource. So this is the beauty of this tool, process indicator. So when would you use a fishbone diagram for this? So fishbone diagram again. So in a fishbone, you would you will discover that the place where you are working. So you will you'll come out with problems like the temperature probe is not working in the radiant warmer, or the incubator is not being put in charging mode before you are transporting the baby, or cling wrap is sometimes not available, or the plastic bag that you are using, it is kind of open, so there is evaporative loss happening. So all the causes that are there, you will come to know by using a fishbone analysis. And the other thing is 5 whys. For example, you have realized that the transport incubator is not being put in charging. So then you keep on asking those 5 whys. So why is it not being put in charging? Because the gynecologist hasn't informed that the delivery is going to happen. So why is the gynecologist not informed that the delivery is going to happen? Because she has put it on the board and assumed that the resident would read it. So why didn't the resident read it? Because there is no policy written that the deliveries which would happen would be listed on the board. So you have come to a root cause that the communication is the problem. So once you address that, or you address the policy that the incubator has, the transport incubator needs to have 100% battery charge, or it has to be in charging mode all throughout the day. So you kind of address the root cause and lead to a better outcome. Yeah, that's true. So even the place where the the 5 whys when you are applying, it can change based on the scenario where you are working. It depends upon the shift or even the place according to the hospital that you are working. So one possibility, an alternate scenario is that where you are keeping the transport incubator, where you are kind of stationing it, it doesn't have a socket, so you are not able to charge it. Okay, the audio is audible. So basically, there is no fixed answers to these tools, like the 5 whys or the Pareto or the process flowchart. They are specific to each system and to each setting. Yeah.
So,
Okay, sir,
yeah.
thank you.
So next we were planning to do a hands-on session about these tools. So we can continue with the pocqi.org, and
Step 2.
you could come here, sir, and just we can continue doing it online. So the delegate here would be doing it online, and I request all the online participants to just follow him, and we'll be reading out loud on. So if any of you have started using that POCQI, the online training module, you can move to step 2. Okay. Yeah, we are just trying to reach up, to the step 2 part. So we are just randomly clicking these. So just ignore these steps. Okay. Do we have any online participants who are who have reached step 2? They can share the screen. So we can do that also. Okay. Dr. Vikas was telling that he had completed. So has he reached step 2, Dr. Vikas? So because this is a neonatal workshop, we are just skipping this. Okay. So we have reached the newborn care flowchart. So, sir, you want to read out loud what you are thinking so that the other delegates can. You just answer the question that is written here. You just read this out and just tell what you are thinking.
Reducing neonatal hypothermia, the team is not sure why so many babies are getting cold, so they decide to use a process flow chart to describe all actions to care for the babies and see if they can identify what is making the babies cold. So we have a newborn care flow chart. Uh, so the delivery happens there, and is there any complication? So there are no complications. So cord is cut, the baby is moved to baby cot, baby is being weight is done, vitamin K is administered, baby is being wrapped, the baby is handed over to mother, and breastfeeding is started. Temperature is taken at 1 hour of life.
So now just carefully see if this order is correct, or if you want to change some things so that the temperature at 1 hour will be better. Do you see, is the order correct what is being followed? Are there any critical steps which you want to bring forward and shift some steps later which are not critical?
I think immediately after birth, the baby should have been dried, and this thing, temperature has to be maintained. But before that, we have to have pre-warm linen, and the weighing of baby should be can be done later on also. So it's not an emergency thing. And the last.
You are right.
So.
So the one thing after you.
Actually, the process chart is beginning with a circle and ending with a circle. So we learned that So the delivery is starting there and ending there. So the process flow chart, this is making me understand the process flow chart, how I should draw. And the complication is decision making, because if the baby is crying and well, baby will be with the mother side, where it is going to take us no, or if the baby is not crying, then it is going. So that decision making is in diamond. So there are two arrows, as already discussed. After that, the sequence, as discussed, I think the sequence should be changed, because weighing the baby is not a priority. And giving vitamin K also can happen later. We should not forget, that's all. And baby can be put to skin contact straight away after the delayed cord clamping.
So, based on the newborn care flow chart, what do you think could be some of the problems contributing to babies getting cold? So, baby is given to mother later. After delivery, baby has been moved to bassinet. Breastfeeding is delayed. Wrapping up. Yes.
All the factors are contributing, so that's why we have
Okay.
two entries. So that's fine. You can click on next. Okay. So thank you. So this is how process flow chart helped us to come to a conclusion that the steps that were doing that was wrong, and we could delay a few not essential steps to be done later, and you could kind of just reorganize, remove the redundant steps, and achieve your outcomes. So now that you have done a detailed analysis of the problem, the next thing you have to do is measure. How do you measure quality of care? So measurement is very important, because measurement is going to give you an objective evidence if you are making progress towards your aim or not. So you can't just tell that, okay, my unit is worsening or my unit is improving in terms of so and so. So you need to have some objective parameters to measure if you are reaching your aim. So that is why process and outcome indicators, this lecture comes into play. So are the slides visible to everyone? Slides are visible?
Yes, sir.
Okay, so then we can start. So next slide. Okay, so all these slides have been adapted from the POCI website. So we are in the second step of learning QI. So what did we do so far? We have listed out all the problems. We have prioritized the problems. We have identified team members. We have written a SMART aim. We have analyzed the problem thoroughly. We have used 4 tools for analysis. I mean, we could use 4 tools for analysis. What are they? The fishbone analysis, the 5 whys, the Pareto principle, and the process flow chart. Now, the next learning is, how do you measure quality of care? So in this, we are going to learn about how to develop indicators for process and outcome of care, and how to use indicators to progress of track improvement. Next slide. So why do we actually need to measure? Because you need to measure whether or not we have an improvement. It helps us to know if we are progressing in achieving our aim. Is there a problem? Okay. Measurement is important because data needs to be objective, because it helps you to communicate with others and among the team members. And it helps us to compare about how we are doing over time. And it helps us to make comparisons with other units that are trying to achieve something what we are trying to achieve. So it is very important to have an objective parameter to see if you're reaching your aim or not. Next. So what is process, what is outcome? This we have already discussed in step 1. So processes are all the actions that you are doing to achieve a result. So what is an outcome? So outcome is something, it is actually the result of all the activities or the processes that you have done. For example, you want to decrease sepsis in your unit. So you want to improve the hand washing rates, hand hygiene rates. So washing your hands to prevent infection is a measure of process. And the incidence of infection in the patients is the outcome. Next. Okay, am I audible again? Because we have changed the audio input.
Yes, sir.
Okay.
Yes, sir.
Okay, yes. So why do you have to measure this process and outcome indicators? So in an ideal QI project, you must have both process indicator and outcome indicator. So why do you need a process indicator? So if you don't have a process indicator, how will you know whether the action you want done is really happening or not? So you are trying to bring a change that all my staff members have to do appropriate hand hygiene. So you are trying to bring in that into your system. So without having this hand hygiene compliance rate, how would you know if this is happening in your unit or not? Next, what if you don't have an outcome measure? So if you don't have an outcome measure, how will you know whether you are making progress towards your aim or not? And for example, all your staff is listening to you, the hand hygiene compliance is excellent, but still, you're not able to achieve your aim, the sepsis is not decreasing. So then you realize that, okay, it is not only hand washing or hand hygiene that is contributing to sepsis, there is something else. I have to look at other problems that needs to be addressed. So for an ideal QI project, you need to have a measure of process and a measure of outcome, both. But sometimes it's not possible to have both indicators in a QI project. So once you start working practically, you will realize that later. Okay, so I'm not going to discuss that about now. Next slide. So how are you going to, okay, what are the qualities of a good indicator? It has to be clear and unambiguous. So all the members of the team should know what is meant by a particular indicator. So we were just playing that game of how an elephant changed to a Hindi alphabet. So the communication has to be good and it has to be unambiguous. Everyone has to interpret that in a similar fashion. And then your indicator should be linked to the aims. It should be used to test change and guide improvement. And it should be integrated into the team's daily routine. Next slide. So how do you develop an indicator? So to develop an indicator, you first need to understand what is the process that is happening in your unit. For example, you want to decrease hypothermia at 60 minutes of late in your unit. So that's the outcome. So before that is happening, what is happening in your unit? So there are live babies that are being born in your facility. After the babies are born, you are drying the babies immediately and you are putting the babies on skin to skin. So this is the process flow that is happening. So for developing a process indicator, or in fact an outcome indicator, what would be the denominator? The denominator would be the number of live babies being born in your facility. So what process indicators would you choose? You would choose the percentage of babies being dried immediately or the percentage of babies which are getting skin to skin care at birth. What would be the outcome? Outcome would be the percentage of babies hypothermic at 60 minutes after birth. So next slide. Again, examples of a good indicator. So the previous slide what we have discussed, is the indicator a good one? So to call it a good indicator, it needs to have all the characteristics described here. You have to clearly define the numerator. So what is the numerator? What are the number of babies that are being dried immediately after birth? So you would get this data from your birth register or from a person who is assigned to look after this. What would be the denominator? The denominator would be the number of normal vaginal live births. So you have to define this clearly before you start working on your QI project, and it has to be clear and unambiguous, because one nurse might think it is normal vaginal live births, the other nurse might think it is all live births. So once you have that ambiguity, your indicators would start showing you false results. So you also have to clearly define what would be the source of these numbers. So in this example, they have defined that the source is the labor room register. So always try to get data easily. So don't try to overburden your staff by giving them new task or doing something or record a lot of things. So they would eventually, it would move out of your system, or they would just actually smudge data. So whatever is available to you, whatever is easy, try to pick up that and start off with your first QI project. You also have to define who is the person responsible. So in this example, the delivery room nurse is responsible. How frequently would you review the data? You would review the data at the end of every shift. So all these 5 parameters have to be defined clearly whenever you are making an indicator. Next. So I would skip the next 2 slides. This is an obstetric scenario. Again, okay. How will you collect the data? So you have to clearly identify and define who is the person responsible for data collection. Clear role allocation. What data sources will you use? Again, whatever is freely available to you. So you encourage your QI team to use the available data first. If that is not available, you sometimes have to collect certain baseline data first, say for about 2 weeks, 3 weeks, and then you have to work on your smart time. So if that is the picture, if you don't have data ready-made with you, then define what baseline data will you collect and how long will you collect. And lastly, how frequently will you collect and how frequently would you review the data. So, okay, so you're collecting data weekly, or you're reviewing it weekly. So what are you going to do with the data? So that will be discussed detailedly in step 3, but just I'm going to give you an overview. So what you are going to use is a time series chart. It is also called a run chart. I think we can move to the next slide. I will give you an example of how a run chart looks. So run chart clearly has a title. Okay. So what is the title? The percentage of NICU admissions with normothermia. Okay, that is the title of the run chart. The x-axis is the timeline. So you have the weeks written in the x-axis. The y-axis is the percentage of NICU admissions with normothermia. So for each week, based on your outcome indicator, you just draw lines. You just put dots, and you then just join those dots, and you get a run chart or a time series chart. So if you actually focus and if you identify something has changed after week 5, so that all babies coming into NICU are normothermic, they are maintaining good temperature. So it is important to include annotations in the run chart. So what are annotations? Annotations are just putting an arrow and writing down what you have done. So for example, at the end of week 1, what you have done, I think, let's say you have introduced a right quality cling wrap, but it didn't work. At the end of week 3, say you have switched on the radiant warmer before the baby came, say that didn't work. Week 5, you have ensured that the transport incubator is working, and then you see the result. So these annotations are important to be included in the run chart because it helps you understand what what you are doing, has it resulted into effect or not. That you would subsequently, we would take an extensive lecture about how to do a PDSA and how to interpret a run chart. But this is just a glance of how you have to interpret the data that you have collected. So the last slide, the key tips. Looking at data over time is critical. Frequent measurement, daily or weekly, is better than less frequent measurement. Actually, the frequency of measurement depends upon the event rate. That again, in the hands-on session, we'll try to give you a better picture of that.
only collect data that you're going to use. Don't overburden your staff by giving them tasks to collect endless data, because if you're not going to use it, there is no point in burdening your staff of collecting endless data. Okay, if possible, try to use the data that is already recorded in your health facility or that is easy to collect. Okay, so after completing this, we'll again move on to the hands-on session. So again, if you could come here, we'll just complete that. It'll take 5 minutes, and then we can proceed further. Probably move to step 3. So any online delegates have something to ask? Okay, let's open the chat box and see, ma'am. Okay, very good. Right. So if you have any doubts, you could unmute yourself or ask, or you could type in the chat box.
Sorry, I have one question. This
Yes,
is Dr.
Dr.
Vikas.
Vikas. Yeah.
Now, for the data source, when you said for example, when you're doing hypothermia, it's kind of very easy. You have a labor room register.
Yes, yes.
One question I have had is, let's say about hand hygiene. What data source will you use for hand hygiene?
So that's a very good question. So normally the labor room registers or your databases won't have data regarding hand hygiene compliance. So what you could use is, if you are trying to test the hand hygiene compliance, so you could delegate a nurse, say at a random shift at a random time, to list out the number of the times where hand hygiene could have been done, and the number of times where hand hygiene was actually followed. So a nurse could actually note that at random times during the day, say for example for about 4 days, 5 days, then you would have a baseline data. So that's what I was telling in one of my slides. In some QI projects, you may not have data that is readily available. You might have to collect some baseline data in order to form an aim or proceed further. So you could do it in this way. So at random time, random nurse would do it. So no one knows that. Ma'am wants to add 1 minute.
Usually, like hospitals have infection control team or infection control nurse.
Correct.
Actually, instead of like overburdening the NICU nurses itself, we can always take help from ID team, like infection control team. So generally how it is done in many hospitals is like they have people who watch them secretly, like they would not, we won't even know that we are being observed or we are being watched. So and regularly they put this compliance chart and send it to QI if you have a quality improvement. As Dr. Raja was mentioning, some of the QI, it will be ready-made, available data sources will be available. Some of the QI, we might have to just tickle a bit, like in the sense, this instead of overburdening the NICU nurse, if you have a team like that, if you can get, they will also be happy because it is their main job. Infection control practice is their main job. Thank you.
Thank you. Thank you.
One more example is you could use video surveillance if you have it in your unit. So you could just review your CCTVs, sit in your room, pick up random times in the day, and just you could note down about if you have hand hygiene is being.
Actually, that's one of the methods we use, because every time we used to use infection controllers standing there, most of them used to become aware, and then they automatically
So
change
you
their
should
behavior.
not disclose about who is actually measuring it and what point of the day or what shift they are measuring it. So if the infection control nurse actually comes to your NICU between 8 to 10, so 8 to 10 everything will be perfect. So there's no point in it's like leaking the secret. No, that's not done. So fine. Any other doubts? Is that okay, Dr. Vikas?
Yeah, perfect. Thank you.
Okay. Dr. Prakash sir wants to ask. So if you want to develop hand hygiene, compliance as a process indicator, so could you just tell us what would be the numerator and what would be the denominator that you are going to put? You can take time. We'll wait.
Dr. Vikas, yeah.
Sorry. So the numerator will be like we said, the number of people actually washing hands, and the denominator will be the number of people actually have entered the NICU that day.
Uh, a better way would be the denominator should be the number of opportunities where you could have performed hand washing. So it is not, hand washing is not only performed when you enter the NICU, you could do it after you have soiled your hands, there is visibly dirty. So the denominator should be the number of opportunities where you could have done hand washing. And the numerator should be the number of times hand washing was actually performed. So is that right? Do the panelists agree?
Yeah, perfect. I think we can have a two process in this. One process would be whether they adequately did all the steps, because like it is not enough that they just wash their hands as just a part of routine work. It should be in a very specific manner or specific steps. As mentioned by Dr. Raja, I think a video surveillance would be easy for us to catch if they are doing all the steps, if it is focused in the near the tap, near where they are hand washing. So it could be a two process. One process already discussed, this will be number of opportunities, total number of opportunities will be the denominator, and numerator will be number of opportunities utilized. The other one would be like again number of times hand washed would be the denominator, and numerator would be number of times it was done with all adequate full steps of hand washing. So it could be split up into two processes.
So in hand hygiene, again, there are a number of ways you could do it. Some people do the 5 moments of hand hygiene. Some people do the 10 steps of hand washing or whatever steps of hand washing. Some people do if hand washing is being done or not. So you could start with a simpler one and then you could, fine tune if all the steps are being done. So, okay, so over to our delegate who is attempting this. So you could just skip the maternal scenario and move
We'll just skip this.
Actually, meanwhile, I wanted to ask one query, which is not related to actual the stuff. What should be the ideal procedure after immediately after birth of a baby? We cut the cord, cut the cord, and should the baby be immediately given to mother on abdomen or to be dried? Should be prior baby should be dried first and then given to the mother, or should be given to mother for skin to skin contact and then dried?
So this is a non-QI related question. So what he's asking is just what are the steps of a normal baby being born. So once a baby is born by a vaginal delivery, baby is vigorous, crying, everything, no other risk factors. The first thing you do is put the baby skin to skin on the mother's abdomen, between the breasts. You just put it there. You could do the initial steps there. You could dry the head, dry the body, remove the wet linen, put a pre-warmed linen on the baby, and let the mother hold. So then you could, after the specified your unit policy, you could just cut the clamp. There you do a delayed cord clamping, let's say 60 seconds. So then you cut the clamp. Then the baby stays skin to skin on the mother till the time the mother is shifted out of the labor room. In fact, skin to skin contact, the guidelines say they have to be kept for 1 hour, and you have to initiate breastfeeding while the baby is on skin to skin contact only. Vitamin K can be given while the baby is on skin to skin contact only. You can delay weighing, so weighing is not a priority. So some units are trying to do it for LSCS also. That's again.
It's okay. Okay. What I'm supposed to do?
This is, you can define the component of how
So,
What would be the data source, person responsible, and how frequently do you want to do?
so our indicator here is percentage of newborns with low temperature, that is less than 36.5 degrees Celsius at 1 hour of birth. So the numerator will be, the options are total number of babies born that have normal temperature at 1 hour of birth. Number 2 is total number of babies born that have low temperature at 1 hour of birth. And total number of babies born that have low or normal temperature at 1 hour of birth. So our numerator will be total number of babies born that have low temperature at 1 hour of birth. So at the denominator, there are again 3 options: total number of deliveries, total number of live births, total number of newborns, live and stillbirths. Total number of live births. So data source.
So where do you want to get this data from?
Labor room register.
Yeah.
Okay. Labor room register. Okay. The person responsible, we have to allocate this responsibility to a staff nurse, labor room nurse. Staff nurse. Okay. Frequency once a week, once in 2 weeks, once a month, or once in 2 months. So earlier, the short turn of time, once a week is the, it should be the frequency.
Is that the only reason, or is there any other reasoning why you have chosen once a week?
If we are not meeting our aim, then we can have retrospectively what is going wrong. We need to again rethink on that.
So, one second. So, do the online delegates have to add anything or any queries that they have?
No.
Yes. Okay, no. Okay. I think most units won't have 1 hour temperature in written in it. So probably case sheets would be having it. You know, case sheets usually have temperature recordings at 1 hour, but you could just collate them in a separate. Yes. So we were discussing about how do we choose frequency, as our participant rightly pointed out, the less the better, because you are going to take corrective action soon if that's not being done. But you also have to see that you get some meaningful data points before you kind of interpret them. For example, the event that is happening, in this the event is the number of deliveries. So number of deliveries, usually there is no dearth of deliveries in most of our centers. So you could review the data weekly. So if, say the event that you are seeing is something very rare. Say it is, let's say postpartum hemorrhage. Postpartum hemorrhage is not that common. So if you have to review postpartum hemorrhage, then probably once a week would be too early. So you need to have sufficient number of times the event has occurred before you need to decide the frequency. Say for PPH, you could review it once a month. So that is also important when you decide frequency.
without knowing what we are doing, we just keep on doing is no good. So we just need to know what we are doing. Next slide, please. Okay. Sorry. So it is important that data measurement, it is critical for QI because based on that, like we will be kind of changing the outcome as well as the process. Next slide, please. Okay, I think Dr. Usha already discussed briefly in the morning, like how a routine research would differ from a QA research. The same thing would hold good for data analysis also. I think most would be familiar with at least the basic stuff, chi-square or independent student t-test, etc., which you do generally for a quantitative analysis. Whereas here it is different, and also it is different from other healthcare measures. So here the data analysis, QA data, one point which all need to remember is it is measured dynamically over time. Okay, so it changes from time to time. And also to evaluate the reliability of the process as well as the impact of the outcome, we need this QA data. Next slide, please. Okay, so here is an example like where there is a measure done before and after an intervention. So before the intervention, some event, say for example, there is a infection which is happening in 1800 newborn babies, and after some intervention was made, and it changed to 3 newborns and 3 infection in 100 babies. So so looking at this bar chart, it looks quite impressive, and the intervention has worked. But like you have to question yourself whether it has really worked. If you see the next charts, so in this particular thing, you see over a period, like so the intervention happened somewhere. Okay, in this A part, you have an intervention after which there is a fall. Maybe it is also little bit getting sustained, so it's good. If you say chart B, it has nothing to do with the intervention. Automatically, things are happening. Say, for example, in 1950s, the neonatal mortality was so high, and right now the neonatal mortality, even whether you are doing something or not, you are going in pace with the rest of the people. So definitely the trend will be to fall, whether it is happening naturally or is it because of the intervention. You will be happy that from 8 to 3 came because of your intervention, whereas in this chart B, you know that it is natural process of decline. It has nothing to do with your intervention. So the next one is C, where even though it had come to a point that's it has substantially reduced, it is not sustained, it is going up. Okay, so that is also not good. So data analysis is done by 2 ways. One is run chart, the other one is statistical process control chart. So run chart as next slide. Okay, before we go on to what is a run chart and what is a statistical process control chart, we just have to have some baseline knowledge of what a data is. Okay, so now, so say for example, what is a data? I'm collecting a sample. So number of gentlemen in this hall and number of lady in this hall will be one such data. So you are kind of counting the number of people. Then the other data would be what are the height of different people who are there in this hall. The other data will be how many of us are hungry now. Okay, so there are different types of data you collect. I'm sure like many of you would be familiar with the data of a quantitative analysis. Like quantitative studies, you will know the data. Here, in QI, there are certain differences for your data. It is classified as either a continuous data, where it is like say time to initiate breastfeeding, time duration of cord clamping. So something like a continuous variable, or it could be a discrete or an attribute data. In your discrete data, again, there can be a denominator or there need not be a denominator. Say for example, if it is a proportion, okay, so a number of male getting infected, so male and female are proportions. So you, or it can be a dichotomous yes or no answer. Okay, so it can be like that, or it can be just a number of falls, number of needle stick injury. So where you do not know your denominator, you cannot say number of accidents. You do not say as denominator as people who are having not having accidents. It's nothing like that exists. So it is only the number of event which is happening. So that is second type. And the third one is rate. Say for example, number of times you have infection in your unit, and you are saying that number of times you have number of catheter days. Say for example, you want to calculate CLABSI, it will be number of times you had infection divided by number of so 100 catheter days, something like that. So it will be rate. So basically, two data, one will be continuous, other will be discrete or attributable. In that discrete itself, you have three types: count data where you do not have a denominator, count data where you have a denominator otherwise represented as proportion, the other one is rate. Go to next. So let us see some examples. So click பண்ணிட்டு அப்புறமா இப்போ okay, so this count data, number of falls, number of falls, number of needle stick injury is called as count data. Rate based data is number of incident per 1000 or 100 days. That will be rate based data. And classification is proportion, percentage of infection, etc. would be proportion. Next. Okay, so you want to answer like NEC, percentage of NEC, we can say that percentage of NEC in the unit. It is a dichotomous, right? Yes, no. NEC is present in this baby or there is no NEC. Then again BPD is yes, no BPD. So that again is a dichotomous data. Time to clamp cord, continuous variable. Medication error. Okay, so rather than yes or no, maybe we can put it as number of times the medication error has happened. It's a discrete attribute where there is no proper denominator. Number of CLABSI per 1000 catheter days. Rate. Excellent. Next. Run chart can be used for three things. One is as a process indicator. Other one is as an outcome indicator. There is one more concept called as balancing effect. Okay, so in the zest of doing a QI, you should not be overdoing certain things. Say for example, you want to reduce hypothermia, you should not land up in hyperthermia. So that will be the balancing effect. So for that also you can put the run chart so that you keep the balancing effect under control. So you should be very thoughtful. You should define all these things in the beginning itself. So what is the process you are going to measure, how you are going to measure, outcome what you are going to measure, and what is the balancing effect you are going to measure. Next. So basically run chart shows a manner in which data points vary over time. An annotated run chart means you have some explanation how these data points behave and whether the solutions you want to test the PDSA, whether it is the annotations are going to give you an answer to this. So basically you are going to annotate in same terms of represent in the run chart itself certain measures. We'll see what it is. Next. So I think benefits we discussed. It will help us. It will help us to go in which direction we should do. Next. Okay, this slide I want to concentrate. So there are you should have a title. Okay, you can put in the top itself what is the numerator and what is the denominator, and your x-axis will be always at time. Like what is the frequency of collection of your data? Like it can be weekly or it can be daily or it can be monthly, whatever it is that will come in the x-axis, and y-axis will be based on what data it is, whether it is a count data, rate-based data, or proportion or continuous data would come in your y-axis. Okay, next. So there are something called as run points. That is nothing but if you see this red dot and the blue line joining. So whatever is the red dot or the run points, right? So to make it very obvious, it is made in two different colors in terms of like red color and blue color. So they are run points. So at least for you to have a median, you should have 10 run points. Otherwise, you cannot construct a run chart. To begin with, you should have a 10 points. You can use median when the data points is less than 20, and you could switch over to mean if the data points is becoming more than 20. Other than that, if you see there in the bottom line, there is something called a stretch goal. Okay, so this is what I have got, but this is what I want to achieve. Okay, so that will be drawn at the end as a stretch goal. So this red line is the median line. This median line you will get for these 10 data points. Okay, so what is a median? Okay, the frequently occurring is a mode. It's a measure of central tendency, correct? So if you arrange in ascending or descending order, the point which is there in the middle is your median. So if you have 10 data points, whatever is coming as middle, you choose that as the median, and then you draw, the line is drawn as a median line. So so you have, say for example, in this thing, what is the infection rate per month in one of the wards they have calculated. So that numerator will be number of infection divided by number of patients discharged for that particular month. So they are calculating the monthly data. And monthly they are putting this points, which is a run point, and calculating the median after you achieve 10 run points. And you have a stretch goal also. So what could have happened there in the month of some June? There is definitely a reduction, right, in the number of infection. So what could have happened there? They would have identified this, taken, so they would have made a PDSA cycle. So we are thinking that we are going to have a class on PDSA cycle in the afternoon, but there some PDSA cycle would have happened there, which made the thing. And this traffic signals, the smiley or the red signal, some of the units does that traffic signals to represent your run chart is good or it is not good. Next. Okay, so what is a run? Run is one or more data points on the same side of the central line. Okay, so we learned about run points. Now I am going to introduce one more concept called as number of runs. Okay, so if you see here, the first circle, so that has only one point, that is one run. The next one which has 4 points, that is second run. So you just keep on calculating. So this particular measure, even though maybe some 20, 25 measures or 25 run points, data points are there, you have only 11 runs. Understood? This is fine? We'll move on. Okay. Why run is important? I'll come to that in a minute. So again, there is one more concept called as the central line itself, the median which you have been calculating in the beginning. After a PDSA cycle, it is coming down. Then you can recalculate your median and have a new median line. Okay, so this is a phase change. Next. Okay, so what are the things run chart should have? Run chart should have a title. Run chart, you can mention it as a run chart with a numerator and denominator, and you can have legends to say what is median, where is the median drawn, where is the stretch goal. You can have legends, and also you have to label the y-axis and the x-axis, and also the annotations. So the annotations are nothing but what you have done, something you have done there, like some PDSA cycle has gone there, so that you can put it as a box and annotate there. Next. Okay, so now basically what are we trying to interpret? We know that chi-square test, when it is coming as a p-value of less than 0.05, we know that it is significant. Like that, how to interpret a run chart, whether it is significant variation or is it random variation? So you have to understand this concept, namely random or non-random variation. Random variation is happening naturally. It is prone for variation. All data are prone for variations. Even if you are measuring temperature with the thermometer, even absolutely 36.5 you cannot get. It will be 36.2, 36.3, 36.6, like that. So you cannot get a spot on of that particular. So variation is normal. So what we are intending to do is to identify whether that variation is a naturally happening variation or is it unnatural variation, or in other words, random variation which is normally happening, or non-random variation. So for that you need to, next slide. Okay, for that there are certain concepts which we need to understand. Okay, so there is something called as shift on astronomical data and trend. Okay, so whenever these things are happening, then we know that it is a non-random variation. Okay, so it could be, the non-random variation could be good because you have done a PDSA cycle, this variation has happened. It could be good, or it could be something which has happened in the unit where you need to do a root cause analysis and do a corrective and preventive action also. So hope I am clear. Like yeah. So what are it's very simple. If there are more than 6 points above or below the central line, it is called as shift. Trend is either 5 points or more than 5 points in same direction, up or low direction is trend. And astronomical data is like way above. Astronomy is like star, looking at the star, way above the line is astronomical data. Okay, other than this, you will be taking as non-random variation when whenever you have too few runs or too many runs. There are specified charts for that to say whether there are too few runs or too many runs. Next. Sorry, say it again. Okay, so actually the whole thing is a run, because all points are, if you will calculate as one run, but in that run how many points are there? A single run is there, but the number of points 1, 2, 3, 4, 5, 6 points are there above the central line. Even if one is touching the central line, you, as long as it is not crossing, you will take it as above or below only. Okay, so that is called a shift. That means there is a shift above the central line continuously for 6 time periods or 6 data points. But your question is correct. You call it as a one run. Okay, because when you calculate too many runs or too little runs, that is important. That point is important, because you will calculate all the runs above the point as only one run. Hope I have answered your question. In this graph you want to know? Nice. Mm-hmm. They are not the same. Trend will cross the midline. It will be in one direction, upwards or downwards, whereas shift will not cross the midline. It will be above or below the midline. Midline means median, whatever you have drawn as median. Astronomical is like way above, like out of the box, outlier. Okay, next. Okay, so that completes the run chart. Okay, so what we learned from run chart is there is x-axis, y-axis, title. There are some data points which will be there. When you will call that as a significant. Okay, like chi-square test, it is very simple. P-value less than 0.05, you know that it is significant. Unlike that, in the run chart, you have to specifically look for whether there is a shift, there is a trend, or there is an astronomical point, or there are too less runs or too many runs. So those are all becoming significant or non-random variation. You need to look why non-random variation has basically happened when you are analyzing. Okay, so next we are going to, previous slide, going to go into another concept, namely statistical process control chart, which is otherwise known as SPC chart. It is a field of, it's a robust tool for analysis. Next slide. So it is basically a graphical display of data over time with statistical testing. And so that will make easy for non-statisticians to detect the process changes. Okay, basically it will tell you whether it is significant or not significant. Next. Okay, so let us think three scenarios here. Time of initiation of skin-to-skin contact in NICU, patient satisfaction feedback form, PCO2 changes in ABG of a ventilated neonate. Okay, so these are some of the things which you are thinking. Okay, next slide. Okay, so here you have three such situation. Extremely quick initiation of skin-to-skin contact in NICU babies. Very low patient satisfaction feedback form. Extremely high PCO2 in ABG of a ventilated neonate. Okay, so everything has happened in a way, you cannot think that it is going to be natural. Your PCO2 of a ventilated baby is never going to be spot on at 40. It will vary, like it will vary to 45, it will vary. But however, you will not react for any of those things. When will you react? Whenever there is an extremely high value, you will be looking for a cause. This is we are doing day-to-day life. Dope will be doing. We'll be checking for dope, isn't it? So whenever there is extremes, you will be checking for a cause, right? Whether how it has happened, what is the, how you can correct it, how you can prevent it. You will be looking at it, right? Okay, next. So how do you know whether there is a significant change or not? When there is a significant change, you look at whether event is with a little control or it is a controlled event. Okay, you don't have a control over it or you have a control over it. And of course, no significant change, it is natural, it is inherent variation. Okay, so go back. Which one do you think you have a control over it when you are running your NICU? Which one do you think like you do not have that much control over it? Control over it.
Feedback, patient satisfaction feedback.
Okay. It depends, yes, exactly. So very low is because COVID. We are not allowing the parent to enter inside and we have restricted the time. Okay, so you cannot control a naturally, or there is some flood which has happened, which has changed something. You do not have a control over it. So it depends on what it is. Okay, so you have to analyze to know whether you have, but you are right, like extremely high PCO2, yes, you have a control because the ventilated baby is under your care. Okay, next. So that's why I brought all this is because why they termed it as control chart. So there is a process. So the process control chart, they named it because they want to think whether there is something controlled and you are going to change accordingly. Next. Okay, like how you understood in the run chart, random and non-random variation. In your SPC chart, you have to get familiarized with one more terminology, namely common cause variation and special cause variation. Common cause variation is a natural variation, whereas special cause variation is unnatural, owing to causes not as a part of usual. It could be intended or non-intended. Again, the process could be stable with only common cause variable, or it could be an unstable process when you are charting with a combination of special and common cause variable. Next. Okay, so this is they are just plotting it, time to get to work daily. Okay, till 19th, okay, so 30 minutes average one person is taking. Suddenly they are, there's something, they dug the road for 2 days, which made the person go late for the work because it took unusually long time. After that, it normalized. Okay, even though it is very high, because of some natural process, it has normalized. So you have to not only interpret based on, so once if you are analyzing why that happened, then you will be able to come to a conclusion. Yes, it is an acceptable thing because it came back to normal, or it is not acceptable. Next. Okay, next. So you know that this is a mean of a normal Gaussian distribution, 50% this side, 50% that side, and one standard deviation will be this side, and 2 standard deviation, next 3 standard deviation. Okay, something very similar, but the standard deviation here used is not the same as that of when you use for a quantitative data. You made it into a site and you calculate a mean and your upper control limit and lower control limit, or plus or minus 3 standard deviation. You are plotting it. Okay, next. Okay, so basically it is a run chart with control limits. You have 2 control limits, namely upper control limits and lower control limits. Next. You saw that for a run chart you need 10 data points. For constructing SPC chart, a minimum of 15 to 20 data points is needed. And your upper and lower limits are otherwise known as sigma. So you use for different charts, different formula for calculating ST, and you remember that this ST is different from what you use as a ST in your routine statistics. Next. Okay, again I am going to little bit like tell about data. Same only, variables, continuous data is known as variable data. Discrete data are attributable data. This attributable data can be as a part of proportions where you call it as defectives, or it can be just a defect occurrences only. There is no non-occurrences. There is no non-occurrence of needle stick injury. So it is only a defect. Why you should understand is because depending on this only you will be selecting which SPC chart to use. Next. Okay, so when it is a continuous data, you will use a chart called as X bar and S chart. The beauty of this is you have one something similar as run chart or SPC chart with upper and lower control limit for mean, one for standard deviation alone. Okay, so X bar is for mean and S is for standard deviation chart. So you will be analyzing not only the mean variation, but you will be analyzing even the standard deviation variations. Here you will have 2 charts whenever this is put. Discrete or proportion is P chart. Whenever you are using unit in terms of rate, then it is U chart. Maybe above there. Okay. I just want for completion's sake to have this so that having attended a QA workshop, you should at least know that, okay, these are all the statistics existing, and run chart is something very, very easy we can use in day-to-day practice. We are going to have some hands-on session post-lunch for run charts. SPC chart, it is available in SPSS, but you would need some statisticians' help to do the charts, but interpretation is easy. Okay, so how we are going to interpret? Next. Okay, So this is what we expect, all the data falling between your upper and lower control limits. Next. So you will look for special cause variation if your run is touching and going above the upper control limit or going below the upper control limit. Next. Even a single point beyond the control limit is significant. Or, sorry, previous rule 2. Okay, rule 1, rule 2. Okay, fine. So it's okay, it's okay. So upper and lower control limit is rule 2, I think. Okay. The other one is something very similar. You have a trend towards upper or lower with 6 consecutive points. Next. Or even 2 out of 3 consecutive points nearly touching the control limits. Next. At least 15 points running very close to the center line. This is hugging each other. They say that these points hug each other. Whenever you get these things, you have to look for special cause variation. You should not leave that, oh, this is natural. Whenever you are looking for any of these things, you should look for special cause variation. Okay, so basically, next. So on summary, run chart and statistical process chart can be used to detect significant variation. Run chart is easy to make, data plotted over time. There are only 4 simple rules to identify non-random pattern. Whereas SPC or Shiver chart is little complicated. You have a upper and lower control limit, which is otherwise known as sigma limit, and you have a set of rules to identify special cause variation as discussed, either hugging each other or a trend up and low, or very near the control limits, or even 1 point crossing the limits. I'm happy to answer any questions. Okay, so Dr. Usha's question is, she has difficulty in putting in Excel. Is there any easy way? Yes, there is a easy way. There are like run charts which we are going to practice in the afternoon session, where you just have to feed the data. The run charts will be constructed automatically. It is given in one of the Wales University website, which we are going to follow. So what is very important is you have different, you have to understand your data. That is the only thing you need. What data you have, whether your data is continuous data, whether your data is a rate data, whether your data is a proportion data, or your data is just a count data. If you understand what data it is, you have to choose that particular Excel and fill in your data sheet under the run chart, including your median, including your points will be calculated automatically. But as a team, you should be able to identify whether it is a non-random variation or whether there is a special cause variation and act accordingly. Any doubts? Chat box. Any doubts from the participants who has attended? It happened to be a pre-lunch session and I have loaded you with some data. It's not difficult. Only thing is because you do not have a straightforward p-value, you just have like few things to remember here and there, shifts, trends, etc., to see whether you have to look for a significant thing. Okay, can I know like whether all of you are there in the WhatsApp group? Anyone not in the WhatsApp group? The delegates who are attending, if you are not in the WhatsApp group, please message us. Any doubts? Amulya, Dr. Raj Paul Singh, Dr. Vikas,
Just join.
Dr. Shamini.
Just join.
No doubts, shall I take you all clear? Yeah, template. I thought like to afternoon. Yeah, that's what we are asking, whether they are all in WhatsApp group. You are in WhatsApp group. No? We'll post a template for you to. You can do it here also. No problem.
இதில் சென்ட் பண்ண முடியுமா சார்? சென்ட் பண்ண முடியுமா? அந்த எக்ஸல் டாக்குமெண்ட் சென்ட் பண்ண முடியுமா?
Okay, so this is a run chart which I was telling, like from Wales University. So you have like instructions here, and if you enter data points, say for example, இல்ல இது afternoon பண்ணலாம். Okay, afternoon we will do it as a hands-on session. We are going to put the link in the chat box. Please click the link and you can open.
Meet at around 2:45. In the meantime, we will be putting the link in the group so that you'll be able to access the folder directly. And you need to download your charts, Excel sheets onto your laptops. Preferably use a laptops. Probably on a phone, you may not get all the details.
Good afternoon again, everyone. I hope you enjoyed your lunch. Now we'll start with the post-lunch session with a hands-on workshop. I'll give it over to Dr. Ashok.
ஆமாம், பிடிஎஸ் எக்ஸல் ஷீட்டு மேம் இல்லை பிடிஎஸ் இல்லை தானே இப்போ ரன் ஷாட்
பிடிஎஸ் டாக்கு அப்புறமா a demonstration of how to do the run chart. இது கேம்ஸ் So this run chart is by one of the University of Wales. We'll be sharing this run chart template. There are various templates for run chart. This is one of it. You can find other health organizations also having a run chart template. So in this run chart, basically, if you see, in the top, they have written like how you should be doing a run chart. Okay, so what are the components and how you should do the x-axis and how you should do the y-axis, how you should do the stretch goal and median. Okay, so basically when you have a data, first thing what you need to do is you need to know what kind of data it is. Okay, so depending on that, you will be using the run chart. So if it is a percentage or proportion, you will be using this chart. If it is a count data, that is just number. For example, number of fall, number of needle stick injury, etc. You will be using this. There is no denominator here, only count of incidents. If it is a rate per thousand something, then you will be using this incident rate per thousand or 100. You can use this chart. If it is a continuous variable in terms of measures, then you should be using this chart. Okay, so this continuous variable chart. So whatever is time to something, you will be using this continuous charts. So now there is one available data which we are trying to enter into this chart and see. Okay, so in this chart you have week 1, week 2, week 3, week 4. The percentage, the KMC, the name, KMC. Yeah, okay. So here we are trying to see how many percentage of neonates received KMC. So this is a percentage or proportion. So that data you have to see, this is a percentage or proportion, because this is total number of eligible babies will be the denominator, numerator will be the number of babies who received KMC. So you want to increase the number of babies who receive KMC. So this is week 1, week 2, week 3, week 4, week 5, week 6, we have this data. So now what we are going to do is we are going to copy this 6. Okay, okay. So we are copying this and we are choosing the run chart. So which one should this be? This is not a continuous variable. This is not an count or rate. This is not a count data. So the eligible thing will be this percentage or proportion. So we know this week 1, week 2, week 3 should be in the x-axis. So you choose the number and paste it. So whatever. So this has come as week 1, week 2, week 3 here. The next thing what you should be doing is the numerator and denominator. Okay, so as soon as I entered this week 6, so it has come here in the run chart as week 1, week 2. So for baseline, to represent that as baseline, here it is written as BL. The next thing would be, this is the denominator, number of eligible babies. So you copy the denominator. And paste it in the denominator column. You copy this is the numerator, number received KMC. So this is the numerator. So you copy this numerator and paste it in the numerator column. So now the percentage is being automatically calculated. The median is being automatically calculated. So there are some things which are not here essential. So you can actually right click and delete it. So for now, we'll delete few and retain some, because we are going to put some after PDSA data also we are going to put. So I'm just deleting few and retaining some. Okay, so if you see here, so this run chart is telling us this is the median line and why this is 0? Fine. So you forget about this particular line, we'll sort it out later. So just concentrate till this week 6. So here you can see that this is the median and you have not yet put the stretch goal. Can you say like what should be the stretch goal here, doctor?
So stretch goal means how much you want to achieve. So previously we were giving only KMC for 45% of eligible population. So how much do you want to achieve? 100%. Yeah.
Okay. So you want to achieve 100%, that is good. But sometimes like your goal of from 40 to 100% might be, you know. So why we are saying is when it is 100, it is good to have a stretch goal of 100%. Your team should not get demotivated that you did not achieve that goal. Sometimes you can do it in a stepwise manner. You can 80%. Yeah, maybe we'll put it as 80%. So here, where should the desired direction of the data? The desired data should be up. So you can put that the desired data should be. Okay, so the desired data direction should be upwards, and this is the green one is the stretch goal, the red one is the median, and your data is the blue line. Okay, so now you know that you have to achieve 80%. So we are going to do some PDSA at this point at the 6th week. So we have the data. Okay, so I am going to copy after this PDSA. Numerator, denominator. Numerator, denominator. So I am just copying this. Correct. Okay, so I'm copying, this is the first PDSA, but this you will not know. You would have done a PDSA at this point. You will be collecting ongoing weekly, you will be collecting and you will be entering the data. Okay, so so we are on a, till now it is a baseline data. Now it is a PDSA week 1, week 2, week 3. Okay, so now PDSA we have conducted at this point. Like we have not finished PDSA. We are saying just for the run chart purpose, PDSA is done. Okay, so number delivered, this will be your denominator. Okay, and this is your numerator. Correct. We will randomly put. Randomly we will put some data. So it's okay. No problem. No problem. We'll put some data. So now among these 15 babies, we achieved for 12. Among this 20, let us say 14 we achieved. Among this 24, we'll put as 18. And among 19, we achieved for 14. Okay. So let us now look at this data. Okay. So now forget about this fall. This fall is spurious because, or if you do not, you want only this data, you can delete the column which is not been used. That's better. Okay, so now we have got this particular data where this is your median and this is your PDSA cycle in the initial days, and after your PDSA cycle, the percentage has gone, and sometimes it is even touching the stretch goal. So now you know that this PDSA has worked. More about PDSA we are going to see in the next lecture. Okay, any doubts or queries? The people who are attending online, are you able to follow?
We have put a link to download this. We have put a link.
Yes.
Thank you. So, Amulya, Vikas, and Shamini, you are able to follow.
Yes,
Raj
yes, no
first.
issues.
Yeah. Okay. Okay. So if you are very clear, we'll move on to the next session of PDSA. If you want us to demonstrate one more run chart for a different scenario, we can do it. What do you want? You can put in chat box or you can unmute and
Yes, please. One more example. Will be
one more
great.
example. Okay, good. So
Time for first assessment. First assessment. Time for first assessment.
KMC. LOS.
Okay,
LOS.
late onset sepsis.
Okay, so now we are choosing late onset sepsis. So we know that late onset sepsis generally would be for a rate. Okay, so now we have baseline which is collected for a few months. Okay, so this is a baseline data. This is for the month. So I am copying the baseline data and I am putting in this Excel. So now what should we choose? So this is not percentage or proportion. This is not count data. So this is rate of data for rate, isn't it? So now I'm copying that in the x-axis. Okay, so this is asking only few data. So now I need to know what is the incidence and what is the days or line days or whatever. So I need to go back to my original collected data, and I know this is the number of late onset sepsis. So I'm copying this number of late onset sepsis. Okay, now you have got number of VLBW infants and number of VLBW infant days. Which one should we choose? Dr. Vikas or Mulya, you want to answer? Which one do you want to choose? There are number
of infant days.
Excellent. So it will be number of infant days. So I am copying number of infant days. Okay, so these are the only two datas we need. Okay, so this one is automatically calculating what is the rate per 1,000 occupied days, and let us see what would be our stretch goal. So it has not calculated median. You want to explain this? Okay. Okay, so here because we have not deleted the rest of the columns, it was not coming. Now we have chosen for this alone, so the median is calculated. So now let us move on to the chart. Okay, and then inclusive import number. Click panni. delete பண்ணிடுவா. One second, we are sorting it out. கீழே. Because we have the number of the Excel is over exceeding the number of columns, it was not coming. Only this much I will include without median to show them.
Okay, ma'am.
So here it's because it is not coming automatically, we are going and selecting the data which we want.
This number of instruments
So this one is showing that so you have months. Okay. So this is rate per thousand. So this is a run chart. So here you have got the for different months. But it's coming as occupied days and there was சரியா வரல. இதில் இப்படி காப்பி பண்ணிட்டு delete போங்க, delete போயிட்டு entire row entire row. Okay.
Just try to select only those cells.
சார் ஏதோ கொஞ்சம் டெக்னிக்கல் எரர் இருக்கு சார், என்னன்னு தெரியல.
Okay, why don't we try the other chart?
அந்த இதுலயே பார்த்தலாம்.
Right. Okay. Actually, some technical glitches which we are not able to sort. I'll demonstrate some other chart here. We'll just put some numbers for them.
Time for first இது கரெக்ட்டா வருது, எக்ஸ்ப்ளோர் கரெக்ட்டா வருது.
So here you have got a data which is time for first assessment. So time for first assessment will be a continuous data. So we are going to copy the baseline on the continuous data. So you go and choose the continuous data.
Different days.
Okay, so you have.
For every 5 days, time of first assessment. For every 5 days, this is a time taken for initial assessment. For the initial 30 days, is a copy paste. This is the date of assessment and what is the average time taken. So that one we have entered. Yes, sir.
Select
So in the x-axis, the date will be coming, and y-axis, the measure will be there coming.
Time, this time, time taken for first assessment.
Correct. So we are selecting the data. So for the initial 30 days. So we can see here the run chart. So you can see in the y-axis there is the average, that is the time taken that is being displayed from the time of first referral in the labor room or in the ER. So the average time taken from the time of birth or from the time of entry to the hospital is around 45 minutes. And you can see in the different run points, that was some days 35, some days it was even 1 hour. So that was the time taken for initial assessment. So during this 1 month period for these different babies. So this will become a run chart, and the midline, the median that is given is 45. So what
can
will
you identify any variables here, like in the sense, is it, what do you think about this run chart? So is there any shift, is there any trend, is there any astronomical point, or is there any runs? Okay. Yeah, so at one point there is, so we are kind of putting this as an acronym STAR. STAR is for shift, trend, astronomical point, and runs, which is too few or too high. So here, yes, you have got one possible astronomical point. Any shifts? Yes.
That's all average.
Yes, so there is a possible shift there, and here you have got a. So from day 7 to day 13, even if it is touching the midline, but if it is not crossing the midline, we are taking it as shift. So this particular area is shift, and is it seen? That arrow is seen? Arrow is seen. Yeah. This particular point is a trend because you have 1, 2, 3, 4, 5 points which is going up. So this particular point is a trend. So you have it. This is also a trend. 1, 2, 3, 4, 5. So there is a trend. There is a trend upward here, and there is a possible astronomical point. Here, like if it had been fallen very high, then definitely it is astronomical point. Unlike a SPC chart where you have upper and lower control limits, you do not have, you just have to see and visually say, okay, this is too far outlier or not. We do not have two less runs or two more runs for this particular thing. You have to calculate the number of runs. So this is one run, this is second run, 2 runs, 3, 4, 5, 6, 7, 8, 9. So there are 9 runs in this stretch of 30 days. So you have a fixed chart for that. So you have to see that chart and say whether it is too few runs or correct number of runs. So there is a like ready-made available charts to say whether it is too less run or too many runs. Okay.
Every you see every pattern, every pattern. So one day of a week it is increasing. So this may be probably a weekend also. So that is actually always happening in all our setup. That is a probable weekend actually. So this is data is for that time it takes 70 minutes.
Possible. Actually, if it is recurring again and again 7 days once for 2 days, then it must be weekend. Yeah. So yes. So we are. Are there any questions from the online participants? This data sheet is being shared in the group, WhatsApp group, and also in the drive we have put. You can take it from the Zoom chat box. WhatsApp group. So if there are no further questions, we are moving on to the next session, namely role play for PDSA.
It is the next step of your QA project.
So they taught us that we need to analyze, we need to do root cause analysis for the problem. Problem is nasal injury. So root cause analysis, many methods they told us. One of that is fishbone diagram, where we need to identify factors under 4 P's, like policy, personnel, procedure, place, and any other factors. So
we are going to first put on a written down policy. We are going to document it about what we are going to do, and we have already identified the people. So we have a team now. So we have also identified the problem, that is especially the size of the nasal prongs, and place where most of the nurses probably do not know, especially the junior nurses do not know where the actual prongs are being kept, or even the scale to check what size nasal prong is being misplaced or not kept at a proper place. So that has to be addressed. And personnel, especially the junior most nursing staff, has to be taught on how to look at the nasal injury, how to choose the exact size of the nasal prongs, and that is how we are planning to progress.
Can I suggest something, sir? Shall we put the process, madam, like the baby is coming, you are bringing the baby, you are identifying that baby has distress, and you are asking us to put nasal CPAP. We are always in a hurry, so we just put the nasal prongs, whatever is available. Maybe like the process, how we are bringing the baby, what we are doing next step. If we put the process, also maybe it might be helpful, madam.
Now, what do we, okay. Now, did you look at the significant factors contributing to nasal trauma? That was primarily we are looking at.
Sir, there are many factors under personal procedure. Also, there are many faults. Policy making also, we don't have a policy. Though the company instruction says this number prongs we have to use for that particular birth weight. Sisters are not knowing, and that instructions they are not going through, sir. So maybe policy or some printouts we can put in the unit as well. In each bay also we can put, sir. And place where the masks are kept also, some people are not knowing. Personal junior staff knowledge level is also less, so education also has to be given. So many factors are there, but they told about a chart where we will identify a most significant factor which is contributing maximum to the nasal injury. We want to tell about the chart.
As we have seen, currently the nasal trauma issues has been identified. Out of this, we found that the x-axis being the nasal trauma and the y-axis being different reasons that we have been talking till now. So out of this, we found that the majority of them belong to the not choosing the correct size mask or nasal prongs. So we thought we'll start at that point. And since we have identified the major point there, we'll start taking care of it, and we'll try to follow this up for the next 3 months and see if we can cut down on it. If the nasal injury doesn't cut down, then definitely we'll start looking into rest of the processes also.
So you identified the major problem is not choosing the correct size mask. Now we'll have to look at how we are going to plan and do and study and act. So that's a PDSA, so which we will, you learn that and come back, and we will, if you need to, we'll proceed with the project. Any other doubts? Okay, so go and listen to PDSA now.
So we have done the analysis and we have identified many factors. Pareto chart was displayed where selection of appropriate mask was not done, which is leading to the nasal injury, most important contributor. But how to go about? There are many reasons for nasal injury. How to go about? When to have a team meeting? We are starting now, so how to see whether whatever change we wanted to implement, whether it is happening or not in the unit. Because all of us are in different shift and are not present during all the time. So how to monitor this, when to have a team meeting, how to see whether implementation is going on smoothly. So learning objective of this session is how to have a team meeting and decide on the ideas about what to change to reach our aim. That is to our aim of reaching the nasal injury, decreasing the nasal injury from 50% to 10%. How are we going to decide on implementation of this change? That is by planning a plan, do, study, act cycle. What change we are going to develop and how we are going to test that particular change. For using appropriate mask size, what change we are going to develop and how are we going to test whether it is working properly or not. So we are planning as a team, doing, we are testing, and we are learning from the PDSA cycle. That is studying what is the result of the change, whether it has decreased your nasal injury, whether it has decreased your hypothermia, or whether it has increased your breastfeeding rate. So what has happened after implementing the change? And if desired effect is not happening, what are we going to do after that change? So all these things we'll be seeing in the subsequent slides. First of all, we need to develop change. We have identified what is the most important contributor. So we'll take a morning example where admission temperature of the babies are less. More babies are having less admission temperature. That is hypothermia. And we have identified many causes like plastic wraps are not used in the procedure. And personal, there is no knowledge among sisters or residents that plastic wrap has to be used for thermoregulation in less than 32 weeks. And place, yes, the transport incubator is not shifted properly, and it is not kept in charging for pre-warming in the labor room, or it is not pre-warmed before shifting the baby inside the incubator. So there are many lacunae we have identified. So we are going to sit as a team. Yes, we are having more babies with hypothermia. These are the lacunae we have identified, and based on the analysis, which change we can make. So why there is the plastic wrap is not used properly, why the baby is not getting transported in an incubator, all these things we are going to discuss as a team. And why do you think using this, bringing about a particular change will make people to use more plastic wraps for all the babies? How it will make the people to use plastic wraps for all the baby? How it will make to follow 100% compliance in shifting all the very preterm babies in transport incubator? So how the change will make them do all these things so that admission temperature is maintained? And if at all we do all these interventions, this change, how it is going to improve the admission temperature? Next slide. So there can be different categories of changes that can be brought about. So one of the category is improving the knowledge or skills. That will come under personnel. No? We identified for nasal injury, for not using plastic wrap, for not giving skin-to-skin contact. The major reason was they did not have knowledge that baby has to be put onto the abdomen and skin-to-skin contact has to be given, and plastic wrap has to be used for less than 32 weeks. So we need to increase the knowledge of nurses or healthcare professionals who are involved in this, and eliminate waste. Sometimes like what Dr. Raja told, the charging point is not there for the incubator, or dry towels are not there for immediate drying of the baby over the abdomen. Towels are kept, or only one towel is available, or drying towels, 2 towels are not there in the mother's side. It is kept in the warmer, but it is not there in the mother's side. If it is in mother's side only, we can easily, without difficulty, the one labor room nurse can dry the baby and put the baby on another dry linen. So there can be this distance, walking for a distance, availability, non-availability near the patient. All this can be reason for not doing the change. And reassign tasks. Sometimes, like we had a blame game. Like resident is telling sister has not seen the nasal injury, and sister is telling it is the responsibility of the resident. So we can reassign the task, and we can tell them like every shift, sister has to see for nasal injury before taking over the baby, and has to document the nasal injury scoring in the NICU chart. So another sister who is coming for the next shift, she will see the nasal injury score and then take over the baby. So we can reassign the task to duty people, different duty people. Reorganize the task. So like what Dr. Raja told, sometimes after cord clamping, they are doing drying. Okay, so what we can do, like what he told, you can receive the baby onto the mother's abdomen, dry the baby while waiting for delayed cord clamping. The cord is still intact. In the meantime, you can put on skin-to-skin contact, and you can dry the baby, put a dry towel, remove the wet towel, and then you can, by the time 1 minute would have been over. But what these fellows were doing is, they were allowing for delayed cord clamping. They were just having the baby in the hand. After cord clamping, they are receiving the baby in the bassinet. They are not giving skin-to-skin contact. So you need to reorganize the process, how it is going, and you need to educate everyone. So it should be like putting over the mother's abdomen, skin-to-skin contact, then you clamp and cut the cord, so that you can initiate early breastfeeding, you can maintain temperature, all those things. So the sequence of things, how it is happening, you can reorganize and improve patient relationship in some specialties. Okay. So testing changes. So what, for example, we will take the baby is having hypothermia at admission, and we have found out that these residents are not, who are going for very preterm deliveries, are not taking any plastic wrap along with the resuscitation kit. And labor room nurse is telling that, yes doctor, we know that plastic wrap has to be put, but it has to be brought from the NICU. Plastic wrap, sterile plastic wrap, but it is not being brought. Most of the times they forget and come, NICU sister and resident. So what we are trying to do is, we are making the plastic wrap available with in the labor room only. We are reassigning the job to the labor room sister. So she should be responsible for making the plastic wrap available in the labor room. And so that all the very preterm, and we are educating her that for all less than 32 weeker, they need to receive the baby in a plastic wrap. So that even it will be our responsibility to arrange. So we are reassigning the task. That because residents are changing, every month they are changing. But labor room in charge staff and labor room nurse will be almost same group. So we are asking them to make plastic wraps readily available in the labor room and responsible for putting less than 32 weeker in a plastic wrap after birth. Okay, so we have reassigned the task. Now we have had a team meeting and reassigned the task. We have had a team meeting which comprise of consultant, neonatology residents, and also labor room staff, our in-charge staff. Everyone has held a team meeting and we have agreed that yes, this we are not at all following for 100%. If 0% is a compliance, we can easily do that change. I will take the responsibility. So we are reassigning the task. Testing changes. So how long you are going to test this change? So who will test the change? Here? Who is going to test the change? Who is the person involved in seeing to that plastic wrap is available in labor room and all less than 32 weeker are received onto plastic wrap? Who has taken that responsibility? Labor room staff has taken that responsibility. So she will be responsible for implementing that change. Though as a team we have decided. And we are going to test a change. How long we can test a change? 1 month can we see? Suppose we have less than 32 weeker delivery, 10 deliveries per week. At least 2 deliveries per day. We are having very preterm babies who are getting delivered. Okay, how long can we check? Yeah, so first we need to do a rapid cycle. We need to see whether it is acceptable. Okay, so we can educate that labor room nurse and we can do it for 1 day or 2 shifts. Shifts means 6 hours or 12 hours shift, no? We can do for the 2 shifts. For the 2 babies who are born that day, they can implement this change. And next day, we will get back as a team. So labor room nurses, we are deciding the change as a team, and labor room nurse is implementing the change. She is implementing for 2 shifts or 2 labor room nurses who are responsible for both the shifts. They are implementing and we are having a team meet next day. Okay. According to the intervention, according to the number of delivery rate, according to the number of very preterm who are born in your unit, you can extend also. Sometimes if in 1 week you get 1 or 2 deliveries, then after 1 week you can have a meeting also. So then you are having a meeting. You are telling whether it is happening. Plastic wrap, whether it is you are able to procure. Are there any difficulty in receiving the baby in the plastic wrap? Are they encountering any difficulty in receiving this? So they are telling, no doctor, plastic wrap we are able to procure and keep. We have procured and kept in labor room. We didn't know how to do. Now without drying, we are receiving the baby on the plastic wrap. That is what the feedback we are getting. Okay. So now, since this change is acceptable among all the team members, specifically the person who is going to implement the change in the labor room, we are continuing with this change. Okay. Like what we told. To put a run chart, at least 10 points are needed. Maybe after 10 babies we need to recruit. Maybe after 1 week. So this, we are having a review meeting as a team. Because we have enrolled some 10 babies, sisters are telling they are very comfortable in using a plastic wrap and they are very happy testing the change. They are telling that yes, temperature will improve. That's what they are telling. So we are implementing the change. We are continuing for 1 week. 10 babies have born in that 1 week, and admission temperature, everything you have checked. After 10 days, you are seeing the trend chart or the NICU data, whatever you are seeing. And from the baseline, our baseline was 50% had hypothermia. Okay, so it has our intention is to decrease it to less than 10%. It is remaining almost static. If you see the run chart, it is remaining almost static. There is no much decrease at all. Then you are having a review meeting. your HOD is asking, you people told plastic wrap we are not using. So only hypothermia. Now we have implemented and all of you were very happy with the change. It is very easy to do everything you told. But the hypothermia was not decreased. Then we again did what can be the additional other causes. No? In PP, there were many reasons like what Dr. Raja told. Transport incubator is not pre-warmed. There is no plug point to put the transport incubator in charging while waiting to receive the baby. All these things also we had discussed. So other factors, personals are not having knowledge. So all these things we had discussed. Policy making. There is no policy. Who has to shift the transport incubator? Whether you need to inform NICU, how long, how much time before receiving the baby you need to inform the NICU. Who will inform the NICU to shift the transport incubator? So there is no clear-cut policy. Many things are there. So HOD is asking, you told that after bringing plastic wrap, all the babies will be having normothermia only at admission. But there is no much decrease in the hypothermia incidence. Out of 10 babies, almost more than 50%, almost 50%, same percentage of babies are having hypothermia. Then one of the labor room staff is telling, sir, we are calling for a transport incubator, sir, but it is taking too long to come. And many times they are shifting in bassinet without putting the baby in the transport incubator. And sometimes transport incubator comes without pre-warming. And here also there is no plug point near the there is no other plug point near the warmer to put in the pre-warming mode while awaiting the delivery of the baby. So these are the problems. So the next problem what they are highlighting is transport incubator. Availability and pre-warmed transport incubator is not available. So what can we do about this? Next, we are making a policy. So next change we are bringing. So one PDSA cycle might not be enough to bring the desired change. That is 50% to less than 10%. We did first PDSA, we planned for a change which is plastic wrap availability, reassigning the task to the labor room nurse. And we did that also. We did that also. We came back after 1 week and we studied also. And based upon the result was it was not satisfactory. There was not desired change. There was not even a significant decrease in the hypothermia. So now what we are acting is we are implementing another PDSA cycle. We are implementing another change. Another change is there is a strict policy that the labor room and the OBG team should inform whenever there is a less than 32-weeker delivery prior in hand, and it should be transport incubator should be pre-warmed and kept in NICU. There must be appropriate information going on to NICU, and it is a responsibility of both labor room nurse and resident who is going for delivery to make sure that it is pre-warmed and shifted. So we are bringing a policy that at least half an hour before these residents are going to delivery room, it should have been communicated that transport incubator will be needed for a very preterm baby. It should be pre-warmed, and there a plug point. A new plug point source of power was identified in the labor room. So this is a next change we are bringing in order to improve transport of babies in the transport incubator to NICU. So next PDSA we are doing. So till we achieve that less than 10%, that is desired target, we will be doing another PDSAs. Suddenly it was going, everything is going on smoothly. It is about to achieve less than 10%. Okay, suddenly what happens is there is a astronomical point, or there is a trend towards increase in the hypothermia. So then when they had a review meeting after some 1 week, they saw that everything, I thought that previous week itself it will come to 0%. Now suddenly hypothermia incidence is increasing. What can be the reason? So the reason what they identified was all the sisters in the labor room who were previously working left due to some administrative issues, and all were junior sisters and new sisters who got recruited, or they were changed from one unit to another, who were very new, who didn't even know that plastic wrap and transport incubator has to be told in advance. All these things they didn't know. So that is a reason for that deviation suddenly. So we need to have periodical team meeting till we achieve the desired target. If there is any gross discrepancy, we need to identify what is the cause for the discrepancy. So after studying what that changes, what is the result of that change, whether it has not done anything good or it has the sisters are not comfortable in doing that, there is so much of difficulty, there is so much of resistance, and it is not possible in the setup, then we need to abandon. Sir, admit. So, someone is asking to admit. And if it is working well, then we can adopt it. So according to if it is not working, some other PDSA cycle is needed. We can adapt and implement another PDSA cycle so that we can achieve the desired target. So this is how we study what is the effect of our change, and we either continue with the same change which we have implemented, or again start one more PDSA 2, PDSA 3, based upon our results and team meetings. All these things will depend upon, all this action will depend upon the results. So planning the test, we already discussed what change idea. Change idea was reassigning the task. Who will make the change? The labor room nurse will be making the change. Where will be this test be done? It will be done in the labor room. When will the test be started? It will be started today, for today or tomorrow. For 2 shifts we will be doing. How long? So for 1 whole day we will be doing this change. That is, plastic wrap responsibility will be labor room nurse, and baby has to be received in the plastic wrap before drying and without drying the baby. How will we know this test has happened as planned? Because we are going to have meeting with the concerned nurse and all the team members the next day, whether they are facing any difficulty or any help they needed, whether it is possible at all. Sometimes it may not be feasible. No, doctor, it is not possible in our unit. They might tell like that. So is it feasible at all? What do we expect to learn from this test? So if there are any difficulties, so sometimes what he told, skin to skin contact and drying the baby. No, doctor, as you told, we wanted to put the baby on the mother's abdomen, skin to skin contact, dry, remove the wet linen, put a dry linen, but that linen is kept far away, and we are having difficulty in doing that over the mother's abdomen. So it is very difficult to bring the linen and do it over mother's abdomen. But mothers are happy only. So we need to learn from the test in the meeting, and we need to do appropriate change so that linens are available near the mother, so that the sisters are happy in doing that change. So what change? Same thing. New protocol for arranging plastic wrap. Same thing. 2 of the nurses who are involved in who are in labor room do the test and document exactly what is happening. Mother is happy. I put the baby on skin to skin contact. Breastfeeding was initiated easily. I brought the linens near the mother. I was able to dry, remove the wet linen, put the dry linen, then initiated breastfeeding within 30 minutes. What it happened? So the sister will be coming and telling the next day, no, in the meeting. So that thing we need to do. Study the learning from the test. So you will ask team members, was the test carried out as planned? If not, why? Is this change feasible in our setting? Do we think it will solve the problem of hypothermia? And does the change improve our indicator? Indicator in the sense, number of babies who are admitting with hypothermia, getting admitted with hypothermia. So adopted, if the change is working very well, it is decreasing the hypothermia, it will get adopted. Adapted, it worked partially. It worked partially. Plastic wrap did decrease the hypothermia, but it not any significant decrease in hypothermia. Then you need to adapt. You need to see what other change you need to add to that, modify the change or add something else to that initial change. Abandon. The change idea did not work well. So many of them were unhappy and it is not possible to do. Then abandon the change. So individual changes. So plastic wrap, transport incubator, knowledge. Instead of checking all this together, one by one, in a rapid cycle, we can test, we can have a meeting, we can discuss how it went. If it went well, it is okay. If it does not go well, we can add on the other change. And think about how conditions change over time. There can be variability. Like what ma'am told, weekend performance might be poor. Or when the new staffs are coming, the performance might be poor. So there can be variability. Multiple changes towards a single line. So this is given in the POCU, where to reduce severe hypothermia in the newborn babies by 50% in 3 months, there are many PDSAs that can be done. So put a cling wrap, wall thermometer in the newborn corner in the delivery room, so that delivery room temperature is normal. So these are the many PDSAs that can be done to maintain the temperature of the newborn babies at admission. What you can do is, it is always, as Dr. Raja told, it is always better to do one change at a time and see how it is working and add on another change if needed to achieve the target. Sometimes we do as a bundled approach, bundled care to decrease CLABSI, bundled care, some set of intervention to decrease hypothermia. But we cannot understand from that which changes worked, which changes contributed well, where was the exact lacunae which brought a significant impact. So even 2 shifts is 1 day only, no, it is very short. So we'll be able to, or 1 week also is very short. What is better is we can do rapid cycles and we can do one change at a time, which will be better than putting multiple changes in the same time in a QI. So while testing changes, it will be easy because only 2 labor room nurses involved. But when you are going to, that 1 day only you are going to test. That 1 week you are going to implement the change in the labor room. So that 1 day will be easy because the 2 labor room nurse who is in our team is going to test the change. It is rapid cycle, only 2 shifts they are going to do. 2 shifts they might find it comfortable. But when doing for a prolonged time, they might think that no doctor, procuring, getting plastic wrap, checking whether it is sterile, using for the baby, that and all is very difficult on a long run, they can tell. And tolerance for failure is high. Even if they are checking whether they can give skin to skin contact and they fail, they come back and say, yes doctor, linen was not available near the mother, so we failed. They won't take it seriously. Maybe if linen is available, we will be happy to put on do immediate drying in term babies. That's what they will tell. So while testing changes, when there are a few members in the team who are involved, the resistance will be less and tolerance to failure is high, and all the team members will think of some changes which will improve the project. Okay, so this is, we are having a post-test after the whole session. So since one of the questions is on donor median model and it was put in the agenda, I just wanted to sensitize the participant. Donor median model, there are many models for evaluating quality of health care, and this donor median model is one of the things. It is just a modification of this Plan, Do, Study, Act. What are the components for evaluating health care in a unit? Okay, so structure measures, what are the resources which are needed to implement the change? Process measures, structure, process, outcome measure. There are 3 measures in donor median model for quality of care. Structure measures, what are the resources and structure you are needing to implement the change. Process measures, what are the changes that has to be done in the process to bring the desired effect. Outcome measures, how the outcome is improving. How the outcome is improving. The another thing I wanted to introduce. So another thing I wanted to introduce. So another entity I wanted to introduce here is, just for all of you to know, any QI project should have something called as balancing measures as well. Balancing measures. Suppose delayed cord clamping you are doing to decrease the need for transfusion. Suppose that is a change you are doing to decrease the need for transfusion. We'll keep it as an example. What unexpected adverse outcome that can happen to the baby? So, we are doing it in a good faith that it will bring a good change. Baby will require decreased transfusion. Some other unexpected adverse outcome. Yeah, polycythemia and jaundice. Nothing comes without a side effect. So that can also happen to the baby. So we are putting a run chart to see the compliance of delayed cord clamping. We are putting a run chart to see proportion of babies requiring transfusion. Okay. Similarly, we can put a run chart to see the balancing measures. how many babies, adverse effects. Balancing measures is unexpected adverse effect because of the change we have introduced. So balancing measures, we can have number of babies with polycythemia or jaundice. There can be some unexpected side effect which we did not expect. So that also can happen. For that, we need to put the balancing measures. Suppose in nasal injury, like what we are playing in role play, no? Nasal injury, sir is telling you people are continuing CPAP for an indefinite period. So only nasal injury is happening. All these interventions we have done, but still we are not able to reduce the nasal injury to less than 10%. Because than the needed time, more than the needed time, you people are simply continuing your CPAP. So we need to be in CPAP as early as possible. That's what sir is telling. What can be the balancing measures or unexpected outcome, adverse outcome that can happen when we are weaning the baby early from the CPAP? Very good. So again, the baby might go on to CPAP. Respiratory distress might worsen. De-recruitment can happen. We did in a goodwill, but there was an unexpected adverse outcome. Though it is doing good for some babies there is some unexpected outcome. So this is what we mean by balancing measures. Any QI, balancing measures also we need to see. Sir, it is not moving. So we have implemented a change. We have decreased our hypothermia, admission hypothermia to less than 10%. Shall we leave it off like that? Shall we stop with that? We cannot stop with that. We need to sustain the same. If you're a little bit loose and you're not doing the same changes again and again after 1 month, the hypothermia incidence will become 50%. So whatever changes we have implemented in the quality of care of the baby, that should be continuing. That changes should be happening. How we will know that changes are happening? Like what we planned during PDSA. During PDSA cycle, we planned some changes. No? How we can ensure that changes are happening consistently in your unit? By the outcome, whether babies are having hypothermia or not. So whether this decrease in the hypothermia is lasting for a prolonged period, even after this QA project is over. It's not over in the sense PDSA, developing and testing changes are over, you have achieved hypothermia, you are going to leave in that month or you are going to consistently follow for 2 or 3 months. Okay, so we should always have a period to check sustenance of the changes. Whatever improvement you have achieved, whether that improvement is sustaining after your PDSA cycle for a definite period of time. Say 6 months or 3 months you need to do. If you are just leaving it and again hypothermia is going to 50%, then whatever knowledge we gained as a team, whatever we learn from each other, learn from the change, everything will go waste. So we need to sustain the same changes and same improvement in the outcome. So sustaining improvement is very important part of QY. So we need to motivate the team. We need to give some positive reinforcement like certificates for the nurses who are involved. And we need to project. Projection is important. No, anywhere projection is important. We need to put run charts outside the unit, outside the department. So this much we have done QA project. We have achieved hypothermia of 0%. Which is in line with the international standards. So there is no hypothermia. We have done a successful QA project. Run charts. So if you put run charts, it will be motivating for your team as well. Whenever they are entering NICU, they are seeing, oh, previous month it was 50%. Now after QA, we are working well, it has decreased to 20%. So next month we will achieve the target. There is some positive reinforcement by displaying all those, your successes, your team successes, everything. And identify some new ways, simpler ways, innovative ways to work, where all the changes can be done even more easier. So all these things will ensure that these changes will not go off like that with this batch of resident. It will be continuing with the team. How much ever member changes, it will be continuing in the unit. So to sustain improvement, you can document the flow, exact flow, and you can teach the people new ways or simpler ways to work. You can allocate job responsibilities, and you can give ownership, like what we gave to the labor room nurse. No, we can give ownership to someone. And senior leaders, they will think, we after before 5 years and all, we didn't receive in plastic wraps. What you people are telling? Plastic wraps might not be that much important. Some senior persons can tell like that, but it should not be like that. From top level to bottom level, everyone should be working towards improvement of the outcome. Yes, yes, there is a change. It has been clearly proved that when they use plastic wraps, it is improving. It is decreasing the hypothermia. So we also need to follow that. So they also need to adapt to the new change and understand the significance of the change. So the new we are talking, no, it will be sustained when there is a new way of working, which is told to the nurses and residents. New way means it should be easier. It can be adapted easily. Adaptation can be done, and it is easy to measure. So how to build enthusiasm for improvement? So first project, we should not be so much ambitious. Select a difficult project. Select some more important projects like hypothermia, simpler changes which can be done, so that success of the first project will lead your team members to be more confident, and they will be coming up more and more QA project. Like starting TPN earlier can also be your next QA project. Once this nasal injury is prevented, yes sir, we have successfully prevented the nasal injury. Now next we should go for QA for giving TPN as early as possible to the baby. What are the changes we can do for that? So team members will be very much positive when there is positive outcome from the previous QA project. And build your team. Obviously, in a QA project or in any unit, we cannot work alone, and seek guidance whenever there is some deviation. Whenever you are doing all the changes, but you are not you are not getting the desired outcome, and you are having so much of resistance from some part, or you are not able to get a particular resource, seek guidance from other QA mentors, and even if it is at the top level, they should be self-learning and improving themselves. And document your work so that you can share with the other hospitals or in forums what you have done, how you have improved the outcome of your babies. And display your progress, as I already told. So key to success, the local champion, a leader who respects others and who is willing to take ideas from others and build up as a team, and incentives. Whenever some QA project there is a success, or whenever there is improvement in outcomes, incentives like what we told, no, we can not only monetarily, they can give some certificates or so, which can encourage the sisters to actively participate in the QA project. And mostly there should not be so much of personal aspiration. It should be like how to improve the outcome of babies. The whole team should work towards improvement of outcome of the babies, and build up a positive attitude among your team members. So that's it regarding step 3 and step 4. Any doubts you can put in the chat box.
So QA should more be your culture rather than the sustenance will happen only if QA becomes the culture of the unit, culture of the institution, culture of all, like rather than as an individual thing. Come here for hands on. No problems.
That's okay, sir. Whatever you write, it is correct only. They should log into POCU again.
The delegates online, please log into POCU. Go to step 3 of POCU workbook. So here they are giving 2 options. So we are choosing newborn health. So this is how to do a PDSE and what you learned from PDSE. It's coming from beginning. Because it's coming from beginning. Online, Amulya, Dr. Vikas, Dr. Shalini. Are you all there? One of you, can you share your screen? If you are in
ma'am.
step 3.
Actually, I've finished all of it, so I will not be
You're
able
not
to share.
able to share.
Because I
Who
already
has done
got the
up to
certificate
step 2 can share? Anyone who has done up to step 2? Amulya? This is going to take a long time. It came actually, step 3 only came suddenly. இல்ல register பண்ணாலும் step 3 yeah? Okay, then you log into your rope. இது வேற ஒன்றும் அலோ பண்ண
सब शुरू से करना पड़ेगा. Do's and don'ts of NSU इसके बाद में है किसी? Do's and don'ts of NSU.
No, do you want to go? But I don't have a. So everybody has done and all before we can go back and come back.
Yours is there? You can log in from here.
Yeah, that's what logging to my.
No, you log in from here.
No, not go to the DRE Prakash.
Okay.
But I don't know till where I have gone to.
You are saying step 3, right?
I don't know. If you want, you can move.
Yeah, please. DRE.
DRE Prakash 1@gmail.com. Step 2 complete பண்ணி faster skip on the phone. Like you can fill in and go.
எந்தோ அது மாதிரி தான் இருக்குடா பாஸ்வேர்ட்
POCQ
all small letter
P alone capital POCQA 75 hours QA 75 hours.
this one then it will come only
Fill it, go there. See, first is move, just open the second.
you need to do this.
But probably they have not completed something in step 1 itself, Uma.
No, it's yours only.
That's what I will not have completed step 1. Go to open the step 1 and complete that.
இல்ல அது கம்ப்ளீட் பண்றது நான் இதுலயே பண்ணேன்.
At least one program.
இல்ல yeah from okay we'll finish one talk by then so that you log in till step 2 so that we'll move from next.
Till now we have seen QI, heard QI, but there is something called QC. there is quality control. But how do you combine both? When you combine both, it becomes TQM, that is total quality management. So when we look away from those numbers, then we look at TQM. Especially the reason most of us took science group is because we hate maths. So let us look at it from that point of view. Use of improper tools. Just like how you have different screwdrivers heads within the screwdrivers itself, each person in your organization, especially in your ICU, would require different type of a screwdriver to be taught. Say, for example, we have an MAS baby with severe PPHN. The baby is on INO with HFO, with 100% O2, and even minimal of noise would definitely drop the baby's saturation. And how do you teach all the people, especially all the stakeholders in the NICU? So we have different types of people in the NICU, starting from your junior doctors, consultants, to nursing staff, junior nursing staff, and your housekeeping. But how do you teach QA for everybody? How do you make sure that this baby comes out safe? So this is where you need to have a strong leader. So you need to have a eagle's eye view to look at the problem from a different angle and say, this is what assign roles, and say, this is how you need to do for each thing. So I teach only up to nursing staff, and I leave out the housekeeping. She starts cleaning and suddenly drops a bowl down. Now who's responsible? So the baby crashes again. So everybody has to be taught the quality management. So always use a proper tool to teach your staff. So the next one is lack of continuous improvement processes. So this will allow a service to stagnate. Once a service stagnates and the other hospital starts improving its services, automatically you'll lose business, right? So it involves discovering the deficiencies that exist and reducing the number of errors that get delivered. And the continuous improvement program can decrease costs by especially decreasing errors. So as you decrease your errors, you don't have to pay indemnity. You can cut down on indemnity, as well as you can actually cut down the cost of covering up things. So you don't have to cover up anything. So make sure, teach everyone, and it's a continuous process. So that if you look at your ICUs, especially, when you get new staff, suddenly the sepsis rate rises. Suddenly the NEC rate rises. So why do you think that happens? Is it just because because of the nursing staff, or is it because of a higher cause? When you look at it from a different angle of view, it is always because of the higher process, because we fail to teach them to hand wash. We fail to teach them how to take care of this baby, especially to use sterilium at every point of care. So these are the points that you need to understand when you think of continuous improvement processes. So everybody has to be taught, every rounds have to be in that way, and every point, every nurse, every staff has to be taught these basic processes. Again, when you stop listening, the workforce will become disengaged. Especially if you look, say, when I go for rounds, the first thing I do rounds is with the nurses rather than the staff, because they are my ears and eyes of the unit. So that is how you need to even start listening from them, and they're the ones who spend a lot of time with the babies rather than the actual doctors per se. So then the rounds with the doctors continue, and this is how the productivity increases and the attrition rate starts coming down. If I start saying only I listen to my doctor, and if I stop listening to my nurse, the critical points are the things that I'm going to miss. If you even consider your junior staff who are working, especially doctors, they look at the baby and they always fail to turn the baby. But as nurses change diaper, they look at the back, they turn the baby, they give a bath. So this is where you need to start inculcating a habit of learning from nurses. Never say, I have learned everything, I know everything. Start learning from your nurses, start learning from your housekeeping. Even they help you a lot, especially when they discard things. and they, you would see that there are some units where undocumented medicines keeps going on. You would have definitely experienced it. But how do you go back, especially if you're not on a night duty, or if you haven't done a night rounds, how do you go back and look at it? So you give them a task to say, okay, if I see this extra in these things, you let me know. So that is where you will learn what is happening in your unit throughout 24 hours. And when you take all of them into confidence, automatically your quality improvement comes in naturally, and you'll be able to run your hospital at a, basically the peace of mind increases. Little time allocated to testing. As Usha said, that once everybody comes to an opinion, I know what I'm doing. And if, okay, I'll do it for a very short period of time, and I'm convinced that this works. And if I start moving into it, definitely that's a mistake on my part. Never do that, because always take everybody into confidence. Probably you may be doing it, but the other person may not be able to do it. The staff may not be able to do it. Just because you have done it this period of time, that doesn't mean that everybody has to follow the same time frame. So do it, test it again, test it probably by third time or fourth time you'll get it right, and it's always a cyclic effect. Misunderstanding the specifications and quality standards. So make sure every team member of your organization understands the standards of quality that you have set and the protocols that have been went through the briefing. And do inspection team rounds. See, inspection team rounds are never always one team. Make sure the team rotates. So if I keep one nurse alone as an inspection team, the people who are very close to that nurse probably would be left out during the complaint registry, and rest of them would be getting most of the incident reports. So make sure the cycle takes place, and the inspection team rotates on its own. Doing the process manually. Now we are in an age of internet. We have Internet of Medical Things. We have HMS softwares that have come in, the hospital management softwares that have come in, and most hospitals are running HMS. And currently with IOMT, every device can be connected to the internet, and all the documentation can be given digitally. So once you have it, your data is very easy to be analyzed. If you go for morning rounds, probably by 10 o'clock, you would find that the whole case sheet, monitoring sheet would be filled with the same numbers, right? This would be the most commonest scenario in every unit. So how do you curtail it? Probably you should put somebody else to look after it. But over time, again, it becomes a routine. And data will be lost, data will be manipulated, misspelled. So all these things would create an unnecessary confusion in the whole thing. And you would also probably have done your thesis with all files piled up, looking at each thing, and after 10th file, okay, next 20 files, okay, let me write what I need. So that's a very common thing that happens. So this is where a cloud-based system where you can access all the data together, and it is right in front of you, and you can easily analyze the data. Do not stop listening. So once you stop listening, your organization is bound to fall. So listen from even patients, because the patients are your customers and their complaints matter most. So once you make sure that the complaints are addressed, the quality improvement automatically starts coming up drastically. And the listening starts from the topmost to the lowest grade employee that you have employed in your organization. So the listening has to be a continuous process, and make sure you find time to listen to everyone in your organization. So we have 8 key principles based on the total quality management. First is the customer patient focus, and the second is strong leadership. The third is involvement of people, and process approach and system approach, and continuous improvement, decision making based on facts. Do not listen to one person and take a decision, and make sure the decision has been based on everybody's inputs, and creating value for the hospital, its clients, and its suppliers. Thank you.
Okay, we are moving on to the next step, step 3. Are you all with us? We are moving on to step 3 of that hands-on session.
Yeah, next. Okay, read the scenario. Okay, basically to reduce hypothermia based on the analysis, what changes actually? Analysis. Akash, go back. Did you get a chance to read that? No, isn't it? I'll just go back.
Options. Provide training to nurses about importance of skin to skin care. Punitive action for not following new process of care. Dry the baby immediately. Wrap the baby sometime later. Put the baby on the mother's abdomen immediately after delivery. Random monitoring of the nurses. Delay cord cutting until 1 to 3 minutes after delivery. Weighing of baby and give vitamin K later.
So what are the changes you would like to bring in?
Providing training to nurses about importance of skin to skin care. Punitive action. I didn't understand this.
Punitive punishment if it is not being followed.
No. Dry the baby immediately. Then put the baby on mother's abdomen immediately after delivery. Then, random monitoring of nurses. Delay cord cutting until 1 to 3 minutes after delivery. Weighing and vitamin K can be given later.
So only thing is random monitoring is like you do not have a process to it. It should be. It's not like sample where you monitor then and there. So that is the only thing. It's not measurable. Yeah, it is not measurable. I think education, yes, but random monitoring is nothing random should happen. It should be in a very systematic way. So, you want to read out loud?
The team realized that some nurses did not know how important it was to keep babies warm. They also used the flowchart to identify that some problems with the procedure of caring for newborns. Some tasks, for example, cutting the cord, were happening too early, and some, for example, putting the baby with the mother, were happening too late. It is critical to look for change that fix place and procedure problems in order to sustainably improve care. If all of your solutions are based on training, then staff will have to work hard to apply what they learned in the training, and any new staff person will require training. If you also address place and procedure problems to make it easier to get your desired outcome, then staff can get better results without working harder, and new staff will be able to provide good care without specific training. In this case study, hospital nurses are not aware of importance of skin to skin care, so providing an orientation on its importance would be a good idea. But this orientation alone will not solve the problem. The way they are providing care also needs to be changed, and skin to skin contact can be started immediately. So the team needs to figure out how to start skin to skin care immediately, how to delay cutting the cord until after delivery, and how to give vitamin K and weigh the baby after breastfeeding.
You have decided to do this following in the same
Yes. So we decide to follow the new steps of care, that is put the baby on mother's abdomen immediately after delivery and keep the baby there while doing the other activities. Dry the baby and clean his or her eyes and cover with a dry towel. Cut the cord only after 1 to 3 minutes. Encourage breastfeeding as soon as possible. Leave the vitamin K and weighing until after breastfeeding has started.
So in your plan, you should have five. In your plan, you should always have 5 W and 1 H. So what, who, where, when, and why, and how. So here you want to answer? Who will test the change? Where will the test take place, etc.?
The options are: nurse in charge will assign any staff, nurse who is interested, enthusiastic, and volunteered, nurse who is hesitating to perform this task. All the nurses can do this at one time. Nurse who is interested, enthusiastic, and volunteered will do the change, will test the change. Where will the test take place? In the postnatal ward, in the labor room, anywhere in the hospital, in sick SNCU, in the labor room itself. How will they test the change? The nurse will try the new sequence of events, that is, put the baby on mother's abdomen. As soon as baby comes out, dry the baby on the mother's abdomen, cut the cord, cord cutting is delayed up to 1 to 3 minutes, and encourage initiation of breastfeeding. How long will the change be tested? Initially for a shift, and then we can implement.
So how long if you want to test it?
Probably 15 days.
Okay, testing itself before implementation testing. Okay, fine. 15 days. Do study. What do you want to learn from this?
What do you want? The options are baby able to maintain a healthy normal body temperature? Is the mother breastfeeding the baby?
What do you want to learn from this test? Study, isn't it? You are testing. So what are the things you want to learn from what you have done?
Yes, definitely. Are babies able to maintain a healthy and normal body temperature? Yes. Yes. Is it easy for nurse to provide care on mother's abdomen? Yes. Do nurses remember to weigh the baby and return care? Yes. How do mothers feel about putting their baby on their abdomen and starting skin to skin? Yes. Yes, everything. Yes.
Okay, so initially, as Dr. Usha was telling, the testing would be for like very short period, like 1 or 2. She had put 2 differences, no, while testing and then while implementation. So testing will be for like fewer numbers. Then if it is working out, the feasibility you are trying, at that point you are studying like many things in terms of like the processes. If you see here, are the babies able to maintain a healthy normal body temperature is more of a outcome. Here you are not in the whatever test you are doing, namely putting the baby onto the mother's abdomen, drying the baby, cutting the cord. Here we are not measuring the temperature as such. So we are not learning that the baby able to maintain healthy normal temperature for this particular thing. And is the mother breastfeeding is more of an intricate question in terms of positioning the baby, like latching is good or not, whether the baby is able to suckle. Those things we are not actually testing as such. Okay, fine. Shall we move on? Act. So, action is like you can adapt this, or like you think that this is not going to work at all, and so those are the actions which you will be taking in your PDSC. So the team decides to try using a new order of care for all babies born in a single shift to learn how do mothers feel, how easy is it to provide, do nurses still remember to weigh the baby and give vitamin K. Okay. So one of the nurses kind of enthusiastic, and the nurse is learning the following. Both mothers were happy to receive the baby. Drying the baby on mother's abdomen was more difficult than doing it on the bassinet. etc. We discussed this briefly in the. What should the team do next?
What should the team do next? One, test that the labor room or reorganization works. Yes, change the process so that nurse will weigh the baby and give vitamin K immediately after delivery. No. Continue to learn if women are happy to receive their baby on their abdomen immediately after delivery. Yes. Arrange the heater in the room. No. Give orders to all nurses, follow the new process of care for all babies. Yes. Provide counseling for all the mothers to have their babies placed on their abdomen immediately after delivery. Yes. Place the baby care trolley with supplies next to the delivery table to make it easier to provide care while baby is on mother's abdomen. Yes. Test whether nurses continue to remember to weigh the baby and yes. नेक्स्ट थोड़ा रॉन्ग हो गया ना उसमें मैडम एकदम ठीक स्टाफ ओके mother are actively taking their babies in this sentence, but we are giving them. Okay. But we should prior counsel them, no? Before putting.
That's what nurse is going to tell, and you can tell the mother to initiate breastfeeding. But it is not part of this change. This change is only putting over the abdomen into skin contact.
Give orders to all the nurses.
So here also we are doing testing it to that nurse only. That 2 shifts nurses only we are doing. We are not giving orders to all the nurses. Only when we are implementing the change, we are finding PDSA is okay, acceptable. Then we will give orders. Give orders to all the nurses.
Okay. Okay.
Those who are online, did you got this point? So here we are only testing in very few babies. One particular enthusiastic nurse is testing, and so we are testing in very few mothers. So it has not become a norm as such, or we have not kind of gone into the implementation stage. But test whether nurses continue to remember to weigh the baby and give vitamin K. This looks like an implementation institution.
So we are yes, even first they are not giving. First they were giving vitamin K immediately after birth, and they were checking the weight. Though this change was made, that baby will be staying on skin-to-skin contact. Though we have implemented this change, that baby will be staying on skin-to-skin contact, early breastfeeding. So the skin-to-skin we have implemented. So it is not affecting the checking of weight or giving vitamin K. They should not forget to check the weight and vitamin K. Even after this process, before the baby leaves to labor room or after giving breastfeeding, sister correctly remembers to check the weight, document and give vitamin K. They are not forgetting that step. Because we have told her that change only, since both the shifts they are very much keen in putting on skin-to-skin contact, they might forget giving vitamin K because they are used to weigh the baby immediately after birth and vitamin K. But even after implementing this change, reorganizing the task, balancing measure. But in process, usually in outcomes, we will tell balancing measure. It is something similar to the balancing measure. Process. We are in the process stage. So.
My query is like whether at this stage, whether they have kind of started implementing. It looks more like they have started implementing. PDSA they have done. What should that name? See, wait. இல்ல previous போட்டுட்டு
One of the nurse will volunteers to test it during the next shift.
okay, so this is only at the end of the shift. Yeah, okay, fine. Not implementing it.
The team agrees that reordering the steps of care is a good idea and should keep babies warm. They feel that the way the room is currently organized makes it difficult. So they decide to move the supply table from the bassinet to the bedside to make it easier to care for babies on the mother's abdomen. As a group, they go to the labor room and move the supplies closer to the labor table. They try two options until they have a setup that people think will work. Then they decide to test if the new organization of the room makes it easier to provide immediate care to the babies while they are in skin-to-skin contact with their mother for one shift. In the next shift, the nurse delivers two babies. She had to reorganize the room again after the first delivery and found that this made caring for the baby much easier. Select the changes that the team in the scenario has tested so far.
So what are the things they have tested? They have changed the order of steps.
Yes.
They have
Reorganize the labor room. How many PDSA cycles have they tried? Three. Five बोला है.
no, how did it become 5? Okay.
The team has carried out following PDSA cycles. One nurse tried the new process of care in her shift and delivered the two babies. The team tested a new arrangement by moving their supply table near to the labor table without any delivery. The team tried one more option for where to keep the supply table. One nurse tested the new arrangement in her next shift to see whether it was easy to provide care to newborns. She reorganized the room again after one delivery. The team decides to ask the nurses on duty for the next 3 shifts to get their feedback on the new room setup and their suggestions for improvement. At the end of the 3 shifts, they have made a few more small changes in the room setup and also involved in the cleaning and maintenance stuff so that they also know about how the room should be set up. 8 babies were born in those shifts. 6 of them had normal temperature at 60 minutes. This is much better than the baseline data. The team members hold a series of meetings for other labor room staff who have not been involved in the project to discuss the new way of working, show them how to care if the baby is on the mother's abdomen after delivery and share the data showing improvement. Other staff members start caring for the babies after delivery in this way as well.
Okay. Yeah, theory. Thank you. So we'll move on to the next session, Ashok's talk.
So, good evening all. So, in this session we will see quality and patient safety is a continuous teamwork. So we all know quality is important and improvement is needed. And it is a continuous team effort. All the team members, team statistics, that all we have learned. So during our medical educations, we are learned, we are taught only what to do, what to do, what to do, what to do, but how to do. That becomes just a practical application and field work. So those aspects, maybe in the new NMC curriculum, they are improving in communication and other things starting from UG. So maybe how to do, how to apply. So knowledge is there, but how to implement it, that also as a doctors, I think it is important for us to know, rather than those managers or other HR teams. We should also know how to manage. So that becomes a little more important for us. So what I mean by quality improvement in healthcare. So quality improvement in healthcare just means, so it is the continuous effort of everyone. So it is just all our healthcare professionals as doctors, nurses, or who are involved in direct care, but also of the patients, family, and researchers, and educators. They are all providing continuous efforts how to improve the quality of healthcare system. So this will lead to a better performance. So of these two things, so the first one is a very big roller coaster ride, and second one is hospital. So which is safer, do you think? So which is safer and lesser scary? Okay, so you think hospital, so those who are in chat box, you can add. So the roller coaster ride, the studies they have shown that is, there is only chances of death is 1 in 1 lakh, those who go for ride. So they have some safety measures, the death is only 1 in 1 lakh. So that's what they have provided. So some events are reported every time. Yeah, maybe you will see. Yeah, that's correct. Maybe, yeah, so that's also is there. Correct. Yeah. Yes, I understand that is there. But you can see some other statistics what they have published. Maybe you will feel really surprised. So you can see in US. So what does it read? Yeah, what does the topic tell? Yeah. So that is the third leading cause of death next to cardiovascular, neurological. The third leading cause is medical errors. So it is there. So the problem is it is underreported. So when they went and analyzed from University Johns Hopkins University, they found that in US only less than 10% has been reported. More than 90% are underreported drug errors, preventable errors, surgical errors. So apart from other routine cancer deaths, other things, so this becomes as a third leading cause. So there is always a scope of improvement. So that maybe we can check. So how does this all the quality improvement start? So where did it start from? So it started not in the healthcare first. So it started first in the automobile industry. So only all these defect, defaults, all these process terms all started first in the automobile industry. So mainly in Henry Ford, Benz. So all they adapted how they can improve the quality of performance of their engines to improve more further. So all the quality improvement started first in automobile industry. Gradually it is adapted to healthcare system. So this all started after World War, 1940s. So there was a huge drawback. And so many books and articles mention Dr. Deming. He is the father of quality improvement. And maybe at the time, if you read the biography, it tells he was first implementing quality improvement in healthcare and advocating legacy in the US, but nobody accepted him. So he went to Japan. And then again, after 2-3 decades, they called him back to US to improve the quality of healthcare. So that is quite interesting. So if you see any, this one skeward chart, that's what we were discussing, that control chart, all this keyword chart. So all these were invented in 1950s, 1940s. And now we are again implementing in healthcare just to improve the quality of care. So all these things are invented, not new. All these are old. And this keyword chart, one of the his tutor in 1930, 1940s, it was implemented in automobile, other industries. So now health also, there is a scope of improvement. So all those things are going on. So what does this EBM tell? Evidence-based medicine. So the two things that will improve the outcomes of them is evidence-based medicine and quality improvement for the good outcome of the babies. So on evidence-based medicine, so what does it tell? How to improve the outcomes, research. So that and all is individual knowledge. So we gather, we term, as a researcher they keep, but how are you going to implement it? That also one of the QA workshop, Dr. Vikram Datta sir, in his first slide he showed. So first 4 researches on antenatal steroids was done in 1970s. So that itself they have shown some 40% reduction in mortality. But till 2010, 2011,
Recording in progress.
okay. So okay, with the second slide there, ma'am. Down is the panel. So it took us almost 5 decades to implement in the hospitals. So there is a huge gap between what is going on in the net is there, net disconnect ಆಯ್ತು sir. No internet, sir. Jio connect பண்ணுமா என்னமோ. Yeah, ma'am. கீழே போட்டு எனக்கு ஸ்க்ரோல் டவுன் பண்ணுங்க.
Continue talking, sir, till the slides are done.
So still we face problems, how to implement it in grassroots level, how to improve the control mother care, and how to improve the antenatal steroid coverage. So all these things will contribute us to decrease the neonatal mortality. So evidence-based medicine and the cure should go hand in hand, and both are complementary to each other. So the next step, so what is the Deming's 5 principles?
They're not letting in. Please ask them to ring.
So what are the first principle? So quality improvement, as we understand, the evidence-based medicine is to understand the science. So that is how it is improving, what is going on, if you do some changes, whether improving or not improving, or case control. So that is just a science. But quality improvement, it is not a science of the medicine field, but it is science of the process. So how to implement it, how to go about it, and how to further improve it. So that is the science of how to improving process. So who has the major stakeholder? So it is the government, and they should be again more promoting. But what is more important? So who should be voicing out to bring about the change? Yes, healthcare providers and advocacy. So maybe we as a doctor should be only the first leaders and foremost leaders to improve the science, quality improvement. So we all know Pareto principle also. Yeah. So next thing, the Deming's second rule is, so all the data should be measured. So if you are telling, so there is no antenatal coverage, so all babies are dying and babies with mothers are not receiving, so they should have data, documentation, so a proof. So somebody may tell, I don't have any RRP in my unit. So that does not mean it's a fantastic unit. So there it just means, if you ask how you don't have any RRP, you don't screen at all. So that becomes,
They are not letting.
so that becomes important for us to measure the data. So whatever problem is there, that may cause a final outcome of
Recording in progress.
Okay. So the principle is you should be measuring the problem. So if you are not measuring the problem, that means there is no, that is not happening. That's what finally happened. Finally, the outcome blindness will be there continuing, but the problem is there is no measurement. So data should be there collected, whatever process should be there, that should be completed. So that's what this one. So the next third rule is managed care. So managed care, that does not mean all the healthcare personnel should be managed. So that is the doctors or nurses. So they should be managed. It does not mean that they should be managed, but that means, so we should, as a healthcare professionals, doctors, we should manage how to process and deliver the care. So that is the very important process. So as you saw in our this one also, all the data, everything was there, but nobody was looking at it and nobody was analyzing it. So it is, as a healthcare personnel, we should look at our data, compare our data if our possible, to see whether we can have any scope in improvement with other units. Audio is not there. Huh? Okay. So we should look at how to improve and in the process of care. So we should be able to check the right data at the right place at right time and interpret it correctly and go about. So this is the fourth important step. And so again, most importantly is engaging the smart cogs. So smart cogs means those who have major influencer. So who will have major influencer in improving the healthcare? We as doctors or neonatologists to improve the newborn or pediatricians to improve the pediatric care, we should only voice out. So those we are only more influential and we are committed to healthcare. So we should voice out with our data and projectors and then go again to improve the QA for a better improved care. So QA is a teamwork. So that's what we understood. That has immediately you can see your results and you can be happy. And if your approach is not working, you can choose another approach. So that is a teamwork of implementing and how to improve. So effective teamwork in healthcare is being challenged nowadays. Previously, healthcare system may not be so much well versed or more technologies, outcomes may not be available. But with the present time, it is becoming complexity. Each patient may be attended by 4 or 5 doctors from different specialties. Any preterm baby, ophthalmologist has to come and look at ROP. Hearing screening, another team has to come. So again, all are important. Hearing screening is important, ROP is important, radiology has to come and people. So it is not just one-man job. So all person has to improve. So it is a teamwork and coordination with the team that again becomes important and complexity of the problems is there. Again, lost connection, sir. Yeah, lost connection. இதிலே பேசிட்டு அவங்க chronic babies and the shortage of all our staff and the safe working hours. The challenge is not whether we will deliver care in the team, but the challenge is how well we can deliver care in the together as a team. So each member of the team may be performing well, but if individually how maybe we are not missing, that becomes a problem because of the complexity of advanced care. So we all learned the PD is a sector and the team stands for together everyone achieves more. So there is a difference between quality and quality improvement. So each hospital there may be a quality cell, so that they may be collecting some quality, collecting and keeping data. So that again is important, and quality improvement is driven entirely by doctors. Both are completely different. So understand that also. So quality standards they may be just collecting and keeping, but we may have to analyze it whether where is the scope of improvement for us, in which area we can improve to show the better improved outcome. So we as clinicians should be involving and trying in this quality of care and as a teamwork, and maybe QA also should be incorporated as just like our communication skills, imparting the team skills that maybe in the NMC, the UG and the PG curriculums, those things are being incorporated. So it has been shown in some studies also that it may result in better understanding of the students of the problems, and maybe in your UG hospital or any person that they can perform an audit so that they can have a clear idea what is going on with the patients and the patient care in the undergraduate curriculum. So if QA is a teamwork, there are 4 stages in that team. So in the forming the team, there are 4 stages. So the first stage is so there may be So forming a team, so where each member may be there, all may be there, but interpersonal skills, so those things have to improve. So next thing maybe is storming. So why should I change? Why should you change? So those things can be there. That conflicts can be there between the team members. So that becomes an importance of that becomes there. And norming. So there. So first thing maybe is team forming. Then storming can be there between the team members. I will not change. You will not change. So those things can be there. Then there may be a stage of norming. There can be open communication between the team members, and they should find a open conclusion. So what will work and what won't work, they should be able to do. And finally, they should be performing. So all teams, teamwork starts from forming the team. So with discussions, healthy discussions, they may be arguing, storming, and they should come to conclusion, and they should perform towards reaching the goal. So that should be the idea of the teamwork. So if those things are there, so we will have benefits. So of improved team benefits, patient care, so all the team members will have a better job satisfaction. And if outputs are going to be high, financial increase, Dr. Sharat was telling that will be high. So those things will be there. Yes. So how to sustain that already Bhushan has told us. The common purpose and shared ownership should be there between all the cadres of the team members, and the measurable goal should be there. As we discussed, from decreasing from 10% to 5%, so whatever is there as measurable goals. So effective leadership should be there. So there may be difference between if I am telling, so to perform a change in the nursing care, and if the senior person who is doing the rounds and telling do change in this nursing care, so there should be effective leadership. So you should be any conflicts is there, maybe yes we already discussed, that should be settled, and there should be trust between each and individual team members, nurses, so there should be individual support team. So this becomes important, and call for help. So if I am not able to perform, I am not able to do this, maybe there should be a time for call for help. So, so there is something mentioned as 3-bucket model. So if anything overfills the problems, there are more problems of errors. So the 3 buckets are lack of sleep or tiredness. So if that bucket is getting full, so it will also spill to errors. The third thing is I am new to the environment. I don't know what to do. So again, any new person is coming. So if too many new persons are there, there are problems that can arise here. So this is the second. And the third one is, so I am not aware what is going on. So I don't know what changes is going on. Communication. So if communications is also not getting, performing better, if all these 3 buckets is getting full, spills will be there and errors will be there. So only to improve the communication, there is especially in the nurses, the most of the problems happen during handovers. Till 9, baby was fine. After handover, baby became deteriorated. So what management was done and what changes what happened in the handover. So that is a major time where errors, prone for errors. So there should be some changes in the nurses and doctors to make effective changes. So some of the effective steps, so that's what that is their steps. They have mentioned this SBAR communication that maybe so many of the units may be following. So SBAR stands for situation, how baby, what is the patient, how it was there, and background of the patient, and what was the action and repeat. So SBAR. So there may be IPOS patterns. So all these things maybe you can search online and then learn how to prove effective communication and professional mutual respect can be done. So QA teamwork, how to sustain this already we have discussed. So next. So what are the barriers? So especially whenever changing roles is there, new persons is there, and hierarchy. So till you are only telling, but it is not coming from the unit chief professor. So all the hierarchy that again will be there still in our system. And instability of the system is constantly changing. So that also becomes happen. So it becomes important for us to understand where we are working, what are the characteristics of the system, what is their knowledge, their style. Prayers. Yeah, this one already we discussed. Dr. Usha mentioned this time. So regarding projection and all these things. So these are the barriers. If everything is changing, and the management also should be supportive. So they should be able to sustain us. Okay, improvement is there. I will support you, either by certificates or anything. So recognition. So all these things should be there. If they are not doing, we will be also becoming tired. So why we are performing. So next, how to report. Once you have done the QA study, how are you going to report it effectively again? So that you have to publish a paper out of it again. So some guidelines are there. So that is called square guidelines. So this may be little bit different previously. This may be a little bit different from our usual trials. So that is called SQUARE, stands for Standards for Quality Improvement Reporting in Excellence. So maybe in the title you have to mention as there is a quality initiative program and structured abstract as usual should be there. In that, apart from the routine your PICO statement and the abstract methods, there is something addition of local problem. So why are you doing this study in your area? So what is the background analysis of the problem? So what is the importance and rationale that we have to address this issue that maybe they are coming in your introduction. Next. Yeah. So in your methods also you have to explain about like your PICO statement you are doing. You have to explain how are you forming the team and who are there involved. Explain how are you going to what intervention that you are going to change. And baseline, that is the context elements. So that is if you are doing a study to improve hypothermia. So then you should tell clearly, so from where are you getting data, who is going to measure, who is documenting it. So if you are going to tell, I am going to look for any other outcome such as mortality rate, so it should be all clearly defined till what is. So those are the things that may be coming, you have to explain initially. Then the interventions in the PDC cycles, how are you going to do, that you should see. And results when you are publishing, in that you should have your steps of intervention on full graph should be there as a run chart with that is properly marked with these PDC cycles, these changes was there, these changes were mentioned. That is annotation should be there in the entire graph. One graph should tell us that all these changes mentioned should be there. And so that will tell us a complete idea of the picture. And you can again discuss what was the benefits and whether any failures or you saw any adverse events, anything that was there and any additional cost was involved. So those things also you will have to add. So QA studies that when you can return and internal validity and external validity of the study maybe you have to discuss and with the funding ideas. So finally, the question may be arising. So what is the level of evidence? So level of evidence, that is entirely evidence-based medicine. But QA we are looking at not at the science of medicine, we are looking at the science of the process, how well we can deliver and address the issues. So what is the level of evidence for a QA team? So it is entirely based on evidence-based medicine. So somewhere between level of evidence of 3 or 4, just about case near to case control or cohort studies only. All these guidelines mentions that QA and project level of evidence will be there because it is not the science of medicine, that is just a science of process, how well we can improve. So the take-home messages, QA is a continuous process from everyone in the team, and it is the science of the process and not the science of medicine. It is science of process, how to improve the patient safety and patient health care. And we should have a data management and how are you going to collect data. That this is very important in your QA team. And teamwork should be there and a positive culture should be there. And we should understand the values of the team so as to sustain whatever goals we have reached. And maybe you can look at Square 2 so to publish your QA data. Thank you.
Okay, so it's like in the random. Camera, sir. Okay.
Any other doubts you have? So with the last probably lecture of the day, probably I would like to take a few minutes on it because already we have spoken about it. I mean, probably this is just a talk about quality indicators and benchmarking. I think already we have seen like what is quality indicators means. Like usually you choose what is the quality indicator that you just see what is the quality of a unit. It can assess your quality of a unit, quality of the care provided. That's your one of the quality indicators. It can be for the nation, it can be for the unit, it can be for the hospital. So you can have different ways of using your quality indicators. Okay, is that clear? So suppose what I'm rate is a quality indicator of a country's healthcare system. Okay, suppose for a unit, it may be like say CLABSI rate. It's an indicator of quality indicator of a health infection prevention measures in your unit. Okay, so you can see you can use the bed occupancy rate will tell you how busy is your unit. So all these are quality indicators where how to calculate is already being taught in the previous session. So numerator will be the times you had number of times you have the opportunities will be the denominator, and how often have you achieved that will be the numerator. In the sense, suppose, say for example, you take the breastfeeding, initiation of breastfeeding in the first 1 hour of life. So if you take that, so as soon as baby is delivered, how many of babies has been fed in the first 1 hour of life? So you say from baby number 1 to 100 is delivered in that month. So baby 1, yes, no. Baby 2, yes, no. Like that you can make it, and at the end of it you can find out total number of yes who have been fed divided by the total number of babies who are delivered during that time. So if we say suppose 40 people have been breastfed in the first 1 hour out of 100, it will be 40%. Now but this 40% which you have achieved, now is it appropriate, or can it be how do you know that you got a rate? You got a health indicator telling that, quality indicator telling that my initiation of breastfeeding, is about 40% in the unit. How do you know it is good? How do you know it is bad? So for that you have to use benchmark. So this benchmarking is something for you to compare whatever you have in the, what you are having in your unit is, comparable with the external, either with the external system or in the internal system. So benchmarking can be two ways. One, you have your own benchmarking first. Suppose say for example internationally the infant mortality rate, the breastfeeding initiation rate is around 90%, and your hospital is only 20%. We cannot try to put benchmarking to achieve 90%. No? So initially you can just have it 30% and from 20 to 40%. And try to achieve that 40% and keep sure that it should not go below, below 40% for initiation of breastfeeding. So that is your benchmark. So whenever it goes below, it means you have to definitely go on to look into the root cause analysis, and you have to do an active action or preventive action. Now this is slightly different. This is also a way of initiating a quality initiative. It's also a way to do a quality improvement program. And this is one of the ways that you may use the topic to do a quality improvement. But then the quality indicators are basically for you to look at does the indicator really reflects the importance of the unit, and also there is it's going to reflect the quality of care in the unit. So and also the way you choose and the parameters you choose as numerator and denominator is very important. If for example CLABSI, you want catheter associated bloodstream infection. central catheter, central line associated breastfeeding infection. In that, the numerator will be number of babies who develop, the denominator will be the catheter days. You cannot take this number of babies in the central lines because every day when the line is given, that is actually poses a risk for infection. So the rate will be, that's how universally it is compared. So you also have to have the same numerator and denominator to compare it with the a system with these standards outside. So that's about your the benchmarking. There are various ways to do it, and you've got preventive quality indicators, you've got something inpatient quality indicators, and then patient safety quality measures. So all these are all things which you can preventive means that when anything you have say for example auditing your hand washing. Hand washing is one of the preventive measures you are taking. So those things can be audited. And the same thing, the numerator denominator will be the same. And if it is ready, if it goes below the benchmark, then we will have to do something about it. So benchmarking is nothing but you select a value which can be comparable and it should be sustainable in your unit. And once you achieve that for a long time, then you have to now improve on your benchmark until you reach the minimum possible standards which is comparable to your to international rate is comparable. Okay, and then what? Yeah. That's about, I think, I'm just making it very short. All you are probably all exhausted. That's very in brief about quality indicators and benchmark. Anything else you would like to know? Yes, every from online, anything specific you would like to know? So we with the are you able to see the screen? Dr. Vikas, are you able to see the screen? Are you able to see the screen? Dr. Vikas, are you there? And Dr. Rajpal, Dr. Vikas. Yes, sir. Okay. Is the screen being shared? No, not mobile, we're sharing from some other screen. Okay. Now nasal trauma. Okay, and then you can see that as we started implementing the first PDAC cycle, it has come down definitely from the peak, but did not reach the target which we wanted to. And then then we had coming down. Then after we did the PDSA 2, we could see that we have achieved the desired result. Okay, so that's how the QI program should listen, and after this you have to continue doing it and show that you are able to sustain the program.
Recording in progress.
So that's about the okay. Shall I wind up with the post test? Exhausted enough. So just can you log into myquiz.org? myquiz.org. Can you just open this myquiz.org and just put in the chat box myquiz.org, and then you just have to just make a registration, and then we'll give you a number to. So can you please enter this number 795 072. Log into myquiz.org, which is there in the chat box, and enter the number 7950. Yeah, once you go to myquiz.org, or I'll put one more link in the just by clicking on this. Did you go? Try going into that. Try going into the myquiz.org and you have to log in and then go through your email login and then enter this number. Is, uh, is anybody trying to join and not able to join? Can you tell us so that we'll wait? Otherwise, we'll proceed with the questions.
We are trying. Please wait.
Yeah, we'll wait. No problems at all.
Sir, we have login, but next feature we cannot find what to do.
Logged in?
We have login to MyQuiz.
Myquiz.org, yeah.
After that, what we have to do?
Is there anything called login?
G.
Yeah, just press login and it will ask for login details. Via Facebook or Gmail. If you don't have, you just have to register.
Register कर लिया, login कर लिया, sir. After that?
You have to enter the play quiz or join quiz. Is there anything like that?
Create first quiz, create quiz, single player, multiple player. Should I go on player?
No, did you open a new quiz?
No.
What do you do? Can you go to the home screen? Can you share your screen?
I am on.
Okay, you do one thing. Can you? There's one more this thing I put in your chat box. Can you click on that and see?
Is there a quiz code?
I am login my quiz on computer and workshop on mobile.
Okay, can you you do this? Can you put play dot? I mean, in front of that myquiz.org, you put play dot. Prefix play dot to myquiz.org.
G. Okay.
So as soon as you put that, they'll ask for a quiz code.
Yeah. Yes. What is the quiz code, please?
Play quiz dot.
Number is 795072. I repeat, 795072. They'll move to that screen. They can't see this.
Play quiz नहीं आ रहा sir. Play.
No. Play dot myquiz.org. Okay. Play dot myquiz.org.
G. Yes. Quiz code.
Quiz code is 795072. 795072.
Yes. Now I can join.
Yes. 38. Have you joined, Dr. Vikas and Dr. Raj?
Yes.
Okay, yes, we can see you joined, yes. So we'll be starting the quiz and you can, answer that. It's a multiple choice questions, yeah.
Yes, sir.
First question is, in research, there is an urgency to implement findings in practice and improve the patient care when compared to QI. Options. true or false?
Where we have to click. Whether we write or
No,
You have to click on it.
you will be seeing.
okay.
You choose yes or no.
Yes.
Is
Okay.
it coming, sir?
Done.
Yes, so,
सेलेक्ट कर दिया मैंने क्या
did you select, sir?
क्या मैंने false को किया था
Yes, sir. It has got selected. So most of you have selected true, but as we already saw, usually what is the difference is in research there is no urgency in implementing the findings. Research study, it just you make some change, you complete the study. But whether you are going to implement the findings or not is doubtful. But in QI, you are implementing the change to be followed regularly in the unit care practices and to improve neonatal care. In research, either you can implement or you might not implement whatever change you are doing. So it is false. QI only you mandatorily you need to implement. So it is better to address all the identified problems in the unit simultaneously. This is true or false? I think all of you have answered. I have given so much of time. As all of you have rightly pointed, we need to prioritize a problem, and we can address only one problem at a time, which is of high priority. So what is this diagram showing? What is it? Either it is a process chart or fishbone diagram or Pareto chart or 5 whys chart. What is shown in the screen? What is this diagram? Okay, so this is a Pareto chart where they have taken reasons for why patient did not receive appropriate antibiotics, and they have found out the most important contributory factor by using this Pareto chart. So conducting a QI for improving iron stores at 8 months of age by doing umbilical cord milking at birth, is it appropriate or it is not an appropriate study for a QI? So it is not appropriate. When will you see whether change is working? When will you again do one more PDSA? It is a long-term project. It can be appropriate for a proper research study. Next question. Donor-Bedian model for measuring quality care consists of structure measures, process measures, outcome measures, balancing measures, all of the above. So, great. All of you have marked most of you have marked all of the above. We saw that SPO plus balancing measures. All those are components of donor-median model of quality of healthcare. Fishbone diagram is used for the process flow, for finding out the root cause analysis, to find the effectiveness of the PDSA cycle, to find the balancing measure, for which we are using the fishbone diagram. What is the use of fishbone diagram? So as all of you have rightly answered, it is used for the root cause analysis of the problem. Outcome indicators can be developed slowly after testing your changes. Yes or no? Great. Like outcome indicators should be well defined before implementing or testing your change so that you will know whether it is what you are going to measure, whether compliance percentage or outcome percentage. QI can be stopped. Once we achieve the target percentage or outcome, it can be stopped abruptly. Yes or no? So as most of you have told, it is no, we cannot stop abruptly. We need to see for sustenance whether the same quality of care is maintained. Data over the time in QI can be plotted using run charts, control charts, both. Sir, have they marked? Okay, you can use both run charts and control charts to mark the change in data over the period of time. Next question. Under the control charts, each type of data has a specific type of chart, like U chart, P chart, like that. Yes or no? Yes, most of you have answered correctly. So, according to the type of data, you will have different SP charts, like U chart, P chart. Though we didn't go into detail, we can just know that there are different types of chart according to the data. Great. Sir.
Hope all of you have learned something about QI. Nice. Okay. And that we have come to the end of the session. Thank you for being with us all this time, even through the downfalls, like, and that net has gone, and in between the power has gone and everything, and all of you stayed through. And thank you very much. So we'll conclude here. Have a great day. Thank you.
Any other feedback?
Sir, certificate.
Yeah, you'll be getting the e-certificate through your mail, registered mail.
मेल से आएगा. Okay.
You'll be receiving a link.
Tomorrow we'll be sharing a link to your on WhatsApp group, or we'll be sending it to you personally. You can download the link. Okay, and it was a very quick day. At the end of this day, I thank all the speakers and delegates for giving us the opportunity to learn how to improve the outcome of the babies in neonatal units, and by looking at analyzing at every step we do every day. In our units, I feel we introduce a change or try to rectify things, but we fail to look at things back and see how the intervention did make actual difference to this thing. So, but today we know how continuous scrutiny of things is necessary to improve the quality of neonatal unit. And now a small gesture from National Neocon team to all our speakers, for Dr. Prakash sir, Dr. Uma ma'am, Dr. Sharat Chandra sir, Dr. Usha ma'am, Dr. Ashok sir, and Dr. Ashok Kogan sir. Thank you. And one more thing.
Yeah, just one last remark. I think it's a big thanks to the organizing team. And we'll have a big thanks to the organizing team. We can switch on the video on this thing. You can take a photograph with you on the board. Can you all switch on your videos? Dr. Vikas and Dr. Rajpal Singh, if you do not mind. So they will just take a video. And I think a big thank to Dr. Sharat Chandra. And so for his, this thing to take, this thing to help us, the audiovisual team, the video persons, and especially the faculties. I think all of us has been discussing to do this workshop in a very innovative way. So we just thought everybody's ideas incorporate into this to come to this level. We feel sorry that because of some technical glitches, we are unable to. No, switch on that. Okay. Yeah. Is he seen? Okay. Thank you so much. And we'll just take a photograph. I think I told him. Dr. Rajpal, if you're there, you can switch on the video if possible. We are just taking a photograph, yeah.
Thank you.
Okay. Okay, right. Thank you so much. And the lone delegate, we thank you for your patient listening. At least in the crowd, you could sleep.